Gentlemen, we have 877 guests joining us.
Wow.
Well, terrific. Interesting, Val. If I start my screen share sometimes before we open the webinar up, it gives me a little trouble. So go back to.
I'm just going to tell the missus that I'm going to be busy for 2 hours and she shouldn't come in and interrupt me.
Okay, sounds good. Good.
Yeah. No pressure, like.
All right, good. Welcome those that are joining us early here. We've got about 10 minutes before we're going to officially launch the webinar. As you're coming in, try and get familiar with the Zoom interface. You can control a lot of what you're seeing on your side. Today, we will be using the Q&A function to ask questions. We won't be using the hands up function. So no need to put your hand up for anything unless Dr. Griseto asks you a question and wants a hands up response. In the Q&A section, we should have our upvote feature enabled. So if you see a question you like, click on the thumbs up and that will upvote that question and we'll make sure Dr. Griseto gets to it sometime during the presentation or at the end. Want to thank all our sponsors. This is the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. Today is something special. We're doing the International Academy of Gnathology Day. So the International Academy of Gnathology has put together our speakers. We started with Dr. Bill Robbins this morning. We've got Dr. Neil Griseto at noon, and then we have Dr. Tom Giblin speaking at 2:30 today. Arkansas has helped us out with our speakers tomorrow, really a nice lineup that they've put together. And on Thursday, the Canadian Academy of Restorative Dentistry and Prosthodontics. We'd like to thank our sponsors, Comet USA, Patterson Dental, and our co-sponsors here in the Pacific Northwest, Seattle King County Dental Society, Pierce County Dental Society, and Snohomish County Dental Society. Your CE credits will be coming from the University of Washington School of Dentistry CE department. So you might see a confirmation email from the WAGD come after this presentation, but that will not contain your CE credit. Your CE credit will come in PDF format from the University of Washington in 2 to 3 days. AGD members, you can look for your CE to be credited onto your transcript probably within 2 to 4 weeks. So no big rush there. Things are just really backed up with all the CE that's going on right now. You'll see some flyers going by, and those flyers have QR codes on them. Please feel free to use the QR codes to register for upcoming CE events. Just a reminder, the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series is made possible because of all our presenters doing these for no honorarium. We really appreciate them donating their time and their expertise. Like to thank the Canadian Academy of Restorative Dentistry and Prosthodontics for sharing these CE events up in the Great White North there. We appreciate it. I'm a proud Card P member, so thanks, guys. If you're looking for more of these webinars, WashingtonAGD.org. If you happen to miss one of the webinars or want to share it with a colleague, if you go to YouTube and go to Washington Academy of General Dentistry, you will find the previous webinars there. We're going to house them on YouTube for a couple of weeks, and then after that, we're not sure exactly what we'll do with those webinars because, you know, the speakers have been so generous to donate their time. Thanks again to Dr. Michael Fling for doing a couple of webinars for us. Thank you to Panky for supplying some of our speakers, some tremendous presentations. Dr. Leanne Brady was fantastic. International Academy of Anathology stepped in early on. Dr. Lane Ochi did a lecture for us. So if you haven't seen that, go to YouTube or go to our website, washingtonagd.org. and click on the YouTube link there, and that'll take you directly to our YouTube channel. We're also on Facebook, so please join us on Washington Academy of General Dentistry. You'll see upcoming events as well. And please share, subscribe to that page so we can continue to bring you CE events. Down the road, we're going to be looking at doing more virtual CE in webinar formats like this. And we also did something interesting this past weekend. We did a virtual hands-on oral surgery course with Dr. Carl Corner, where we actually sent out models, instruments, handpieces to our participants. And we did a hands-on course for 2 days via Zoom. So it was kind of groundbreaking and it was a lot of fun, but be looking for upcoming offerings from us. You'll also see there's 1 or 2 slides in here that are not free webinars. They're just announcing upcoming CE events that the Washington Academy of General Dentistry is hosting. That includes Dr. Bin Tran has an orthodontics curriculum that he puts on, and Dr. Yassine has a implant continuum as well. During the COVID-19 crisis, Dr. Yassine has put together a little implant study club. It's multiple modules there. It's available on the webinar and available live. And I believe we have him on Friday again this week, and there'll be one more next week before we get back into our offices. Like to thank the University of Washington School of Dentistry, Academy of General Dentistry student chapter for their support and their selection of last Thursday's speaker, Dr. Ann, who did a wonderful presentation on intraoral scanners. It's one that really, if you're doing intraoral scanning, you need to see. Share it with your staff members as well. And that's at on YouTube as well. There's the QR code for our YouTube channel. Remember, like, subscribe, ring the bell, and you'll be notified of upcoming CE events. We've selected our 2020-21 Master Track speakers. That's a heck of a lineup. That flyer just went by, but you can access that curriculum online. The way we do our Master Track program is we have 4 sessions in a year, and each session we have up to 28 hours of CE, hands-on CE. So if you're looking to become a master's in the Academy of General Dentistry, that is a great course. We have our own educational center here in Seattle. It's at SeaTac, so really easy for people to fly in. We have people come in from Idaho, Montana, Alaska. We're close to the airport, so yes, they just stay there, and then we have our Master Track program 4 times a year. And some of the speakers that have presented webinars are actually going to be our speakers during the Master Track program. Don't miss this Wednesday. We've got the Brays back, and they're going to be talking again about PPP loans and all those business aspects of getting back into our offices. Terry Harris is back on Wednesday afternoon. Hey, we apologize that some of you weren't able to get on to Terry's webinar live last week. Quite simply, we have a Zoom account that allows us 3,000 people, and it's just cost prohibitive to add more than that at this time. But all the webinars that are part of the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series are on our YouTube channel, and they'll be available for a period of time. We will be issuing CE credits for live webinars. We cannot give you CE credit for watching a webinar after the fact on YouTube. Sorry, we just don't have that capacity. So getting close to the hour here, and just looking to see, yeah, we've got over half of you have logged back in. Appreciate those of you that joined us this morning and then are going to join us again now. Your support has made it easy to attract speakers to come and help us out. So, okay. CE credits will be coming from the University of Washington School of Dentistry CE department. Look for an email from the University of Washington, and there will be a PDF that you simply type your name into or print and fill your name in. You don't need anything more than that. It doesn't have to be personalized to receive that CE credit. Today, we will not be using the chat feature for Q&A. We're going to be taking questions in the Q&A feature. We probably won't be using the hands up feature at all, but unless Dr. Griseto asks for a show of hands on anything. So we won't be unmuting anybody to ask questions. We're going to just kind of boil those Q&A questions down for Dr. Griseto, and depending on how he's moving through the presentation today, if he sees one that he wants to answer before his presentation is up, he will handle that. You can upvote if you like a question that's being asked. And again, thank you to our panelists, Dr. Gary Hayamoto for handling the chat features there and providing more information. We want to thank our Executive Director, Valerie Bartoli, for all her hard work on putting these webinars together. And we'd like to thank our webmaster, Dr. Pressett. So thank you to everybody that's putting this together. It's really kind of just a skeleton crew of three or four of us that are doing this, but we've been able to do this because of the support of organizations like the International Academy of Nathology, the Canadian Academy of Restorative Dentistry and Prosthodontics, and the Arkansas AGD. Thank you guys for supplying speakers this week. It took a lot of heat off us. Well, it's 12 o'clock noon. We have probably 75% of our participants have now logged in. And for those of you that are just logging in, yes, this is the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. We appreciate you joining us. We'd like to thank our co-sponsors, University of Washington School of Dentistry CE Department, Comet USA, Patterson Dental, the Canadian Academy of Restorative Dentistry and Prosthodontics. We'd like to thank Pierce County Dental Society, Snohomish County Dental Society, and Seattle King County Dental Society for pushing the emails out to their constituents. Again, we want to thank this week's real big co-sponsors, and that's the International Academy of Nathology, Canadian Academy of Restorative Dentistry and Prosthodontics, and the Arkansas Academy of General Dentistry. To sign up for additional webinars, use the QR codes that are going by on the flyers or go to washingtonagd.org. Those QR codes should take you to the website. If you have any troubles and you miss a webinar or you get kicked off and you want to see it, these webinars will be on YouTube within 3 or 4 hours. Our YouTube channel is Washington Academy of General Dentistry. Don't forget to visit us on Facebook as well. We would appreciate that. And thank you again for all the kind compliments and comments that people have shared with us. This has been really rewarding for us, and we appreciate both our speakers and you for joining us. It gives me great pleasure to introduce a friend of mine from the International Academy of Nathology. This is Dr. Neil Griseto. He's a clinical prosthodontist and instructor in predoctoral prosthodontics in the Department of Restorative Dentistry and Biomaterials Science at Harvard School of Dental Medicine. He graduated from the University of Dublin Trinity College in 2006 and practiced general dentistry in the Dublin, Ireland area for 5 years until moving to Brisbane, Australia with his wife, where he practiced for 18 months. Upon being thrown out of Ireland, he returned to, Australia. He returned to Ireland in 2012. He worked as a general dentist in his hometown of Limerick for 4 years until commencing a residency in prosthodontics at the University of Texas Health Science Center at San Antonio, which he completed in 2019. While in Texas, he received the McHorris Award for first place in the Resident Table Clinic competition at the International Academy of Gnathology Congress in 2017, first place at the American Equilibration Society poster competition, and the Roland M. Meffert DDS Endowed Award in Implant Dentistry in 2018. He became a diplomate of the American Board of Prosthodontics and a fellow of the American College of Prosthodontists in 2020. Welcome, Dr. Griseto. I am going to stop sharing my screen. Thank you, sir, for taking time out of your schedule. I know you're doing a lot of these, so welcome.
Thank you so much. Thanks, Dr. Hess, for your kind introduction. The check is in the mail, so thanks for making me sound so fantastic. Yeah, I have been doing a lot of these. You know, the school is not really running at the moment, so we've been doing a lot of teaching from home, which has been kind of good and kind of, you know, it can get a little bit much at times, a lot of video chatting and stuff like that, but I've actually been enjoying it. It's a different format and allows a little bit more interaction, so it's been good so far. So yeah, I think I probably should get going because I have a lot of slides and a lot of things to talk about. So let me just share my screen here. Hold on a second now. Let me just stop the share here. Let me just share the screen. Here we go. Now, I will just at the bottom, let's play. All right. So I presume everybody can see this, I hope anyway. So the title of the lecture is Diagnosis Denture, which is Diagnosis for Dentures and Dentures for Diagnosis. So a lot of diagnosis and a lot of dentures. So yeah, I wanted to talk about this because, you know, dentures form a critical part of our treatment ability, and it's something that, you know, certainly before, while I was practicing as a general dentist, caused me a lot of frustration. I can say trying to get some successful outcomes and predictable outcomes, and you know, I learned as I went on that that I could get more and more predictable outcomes if I was more and more accurate with my diagnosis. You know, there's certain things that are unachievable with dentures. So I think it's really important for us to be able to talk to our patients with that in mind and say, and be able to communicate to them what's realistically achievable for them and what isn't realistically achievable. And there's lots of factors that go into that, you know, not just what the patient presents with, but also your own skill set. So I've been thinking about this for a while. You know, there's a lot of complicated things that go into denture diagnosis, and I've been trying to simplify it even in my own mind so that, you know, with a patient presents in the chair, when you're in a busy practice, to be able to look into the mouth really quickly and look at some obvious features that the patient presents with that can maybe make your life a little bit easier in terms of achieving a predictable outcome or communicating to the patient what is in fact realistic or what isn't. So I think Tim did a great job. He already introduced me. I've got my little Irish flag and my American flag. These are my shields for the three institutions. It's Trinity, San Antonio, and now Harvard. So I'll just do a little presentation map just to give you an idea of what we hope to talk about today. So the first thing is anatomical expectation for outcome. So that's the features of the patient's mouth that present that will determine whether or not we can be successful with a denture. And we're going to talk about that with respect to the maxilla and mandible because they're entirely different. I'm going to go through some example cases that maybe we can possibly get some interaction there and get some opinions on what people think. We'll talk about aesthetics, vertical dimension, lip support, and then we'll go into some implant planning stuff. And I'll talk about the analog and digital workflows. So I think everybody has seen a patient like this sit in the chair at some point in their dental life. They come in, they seem pretty unhappy with their existing dentures, and they're not too comfortable sitting in the chair, not too communicative, and you know, there is a broad spectrum within patients as they present like this. But you know, if we can get to the point where the patient will open up a little bit to us and will allow us to treat them, and we can determine that we can get a fairly predictable result based on what the patient's desires are, we can end up with something that's, a pretty good outcome for most people. I think dentures are very much maligned. I mean, I've been working in the dental school for about a year now. Most of the dental students really they're not too comfortable with them, and I wasn't too comfortable with them when I was in practice. And even now, I'm still learning all the time about how to improve my outcomes. But like I said, the big thing is going to be a diagnosis, and the first part of that is nothing to do with the physical presentation of the patient. It's the patient's personality type, and some of the things that we can talk about with regard to that come from the historical literature. So this is from Devan. He's kind of a hero in prosthodontics. Every prosthodontic resident will have heard this one, and lots of dentists will have heard it too. It says the dentist should meet the mind of the patient before he meets the mouth of the patient. And this comes from a journal article published in the Journal of American Dental Association, 1942. And I thought that this is interesting because now we talk a lot about patient-centered care, and that's something that comes from the medical model. And actually, I looked that up, and I wanted to see what the history of that patient-centered approach is, as opposed to other more paternalistic models that we used to use, as in the dentist knows best, and we would voice treatment on patients. I think we're probably ahead of our medical colleagues on this, because the history of patient-centered care really only dates back to the 2000s. That's as far back as I could trace it in the literature. And here we are with a prosthodontist from 1942 saying we should really talk to the patient and understand what their desires are so that we can tailor the treatment to what they want, because not every patient is the same. And so if we want to talk about historical personality types, I should, caution that there's not a lot of science behind this. This is eminence-based. In other words, it represents the opinion of another kind of well-known prosthodontist called House. And he divided his patients into personality types, philosophic, exacting, hysterical, and indifferent. And we'll go through each of those on their own, because I actually think they can be useful. It's not something even that you would make a note of in the chart, because the language is a little bit inflammatory even, but it's historically based. So House said the philosophic patients are those patients that are easygoing, congenial, mentally well-adjusted, cooperative, and confident in the dentist. And he said that the prognosis is excellent for those patients. And I think that, unfortunately, in my experience, that probably represents a small proportion of the patient population that I get to see. And maybe that's because now I'm specialized and I get to see more of the more difficult patients, but these patients are great. They work with you, and they're pretty happy with how things go, and they have realistic expectations for outcome. That's the most important thing. The next group of patients would be the exacting patients. And these patients are precise, they're above average intelligence, immaculate in dress and appearance, often dissatisfied with past treatment, doubt the ability of the practitioner to satisfy him or her, and often want written guarantees or remakes at no additional charge. Once satisfied, an exacting patient may become the practitioner's greatest supporter. So this is an important group, because oftentimes they are demanding, but what they want is achievable. And that's a really important distinction to make. And that's for each individual practitioner to make sometimes too. Like, it may be something that is achievable for someone, but it may not be within your personal skill set. And I would say that that's really important to know, because if you know that you can protect yourself from less than ideal outcomes and other problems with the patient, a dissatisfied customer or dissatisfied patient is not a great practice builder. So that's an important thing to consider too. The third group are the hysterical patients, and this is where the language starts to get a little bit inflammatory. This is definitely not a medical diagnosis. These patients submit to treatment as a last resort. They have a negative attitude. They're often poor in health, are poorly adjusted, often appear exacting, but with unfounded complaints, have failed at past attempts to wear dentures, and have unrealistic expectations. Hysterical patients often demand aesthetics and function equal to or greater than natural teeth, which we all know is basically impossible. There's nothing that we do in dentistry that is the equal of a natural tooth, I'm sorry to say. The prognosis for these patients is generally poor. And so we'll talk a little bit about that shortly. The last group of patients are the indifferent patients. And those patients, they're not really concerned with their appearance. They often go without dentures for years, or they wear poor or worn out dentures far beyond serviceability. They don't persevere, they don't adapt well. These patients, they don't have any desire to wear dentures, and the most important thing here is they don't value the efforts or skills of the dentist. So what I would say is, like, these four categories, it forms more of a spectrum, in my opinion. There's crossover between each. Like you could get a patient who's mostly philosophic, but has some small exacting demands. You could have a patient who's largely indifferent. In other words, they're not driven by aesthetics, they're more driven by function, or, you know, they just want something to fill a space in their mouth. They don't really care how it looks, they just want to get it done and over with. So like I said, there's a kind of a spectrum between here, and you kind of have to really sit down and spend a little bit of time with the patient trying to figure those things out. So if I were to categorize these, I would say, I've color coded them here. The philosophic patient, that's green means go. You can essentially move forward with treatment without having too much worry that these patients are going to give you problems. And this isn't just for denture patients, even though this comes from the denture literature. This goes for every patient. If you see the patient, you immediately build a good rapport with them, and they seem to understand the risks and benefits of treatment, which sometimes is a difficult thing for patients to grasp, then I think it's more than appropriate to move forward. The exacting patients and the indifferent patients, I would urge a little bit of caution. I think with the exacting patients, they're definitely more time demanding. So it takes more time to figure out exactly what they want. And sometimes that time is something that you can't always charge appropriately for or make economical in a practice. So that's something that you have to decide whether it's right for you or not when you're trying to execute these types of treatments or treat these types of patients. But on the other side of that, there's tremendous benefits from treating patients like this, because oftentimes, especially if you have some more training or you have confidence in treating complex cases, these patients will be more open to having more complex treatment done, things that take more time and end up looking better, functioning better, or more satisfying from the practitioner's point of view. So you have to be careful with them, but at the same time, they can have a benefit. I'm going to skip the hysterical and jump to the indifferent. Again, these patients, you got to spend a little, it may not be worth your while spending more time trying to elucidate what they want, because sometimes the patients in this group, they'll come in and they'll tell you straight away, I just want a tooth. And the mistake that I often make is I spend a little bit more time with them, and then they end up frustrated. That's happened to me more than I can count in my career, that I want to really spend time figuring out what the patient wants in order that I give them the outcome that they need. But the indifferent patient, a lot of the times, they'll just tell you the minute they sit in the chair. They're like, I want teeth. Can you just give me some teeth? Rather than, going through a whole diagnostic process where you figure out what kind of teeth that they want. So I want to move on from that, and we'll come back to it later in the presentation when we learn a little bit more about diagnostics and what is appropriate and what we can expect from dentures. So this terminology, anatomical expectation for outcome, is something that I learned from my mentor, Dr. Haney, down in San Antonio. And I think it's a really good way of thinking about denture diagnosis. In other words, when looking at the patient's anatomy, what can you reasonably expect to achieve with a denture? Because not all patient anatomy is conducive to denture treatment. And so when we look at all of the factors that go into a diagnosis and trying to prognosticate with dentures, it's very complicated. This is just a selection from an article by another mentor of mine, Dr. Phoenix, and his writing partner, Dr. Engelmeyer, who's I think a director of PROS program in Penn. There's a lot of factors here. There's a lot of things to look at. I mean, how much time would it take you to go through all this, to figure this out, to put it into a kind of diagnostic matrix and figure out how this is going to turn out for the patient? So I've been looking at this. While it's fairly comprehensive, there's not much that you're going to miss if you read this article. God, it would take you an inordinate amount of time to get through this for the patient. So I think it's really good to break this down into three concepts for a denture success: support, stability, and retention. And there's a little bit of confusion around this terminology, so hopefully I can make some clarification here. So support is the ability of the denture to resist displacement towards the tissue, okay, away from the occlusal surfaces of the teeth. Stability is a horizontal resistance, so it stops the denture from moving side to side or in a direction that's perpendicular to the occlusal plane, okay? And so this is where some confusion arises between support and stability. Our intuition tells us that when we talk about stability, we put our fingers in the patient's mouth on top of the denture and we rock the denture back and forth, and then we deem that denture unstable. Well, that's not actually probably the best way to think about this, because if you're thinking about an unstable denture that rocks back and forth, that's actually a lack of support for the denture, because that rocking is usually in a direction that's parallel or sorry, perpendicular to the occlusal plane, right? And the stability motion is one that's in a direction that's parallel to the occlusal plane. So that sometimes elicits some confusion. So the last thing then is retention. And that retention is the ability of the prosthesis to resist displacement in a direction that's away from the tissue or towards the teeth. Okay, so support is towards the tissue, retention is away from the tissue, and stability is horizontally, right? And so now we've taken a bunch of different factors and we're going to apply them into these three groups and see how we're going to do, okay? So again, support towards the tissue, stability side to side, and retention away from the tissue. So let's talk about support first. Again, we've got all these multiple factors that can go into play, and we're going to talk about maxillary support first, okay? So let's knock out a bunch of these factors and talk about the things that actually have a significant role to play. Palatal vault shape, ridge form, tori, bone quality and quantity, mucosa thickness, and mucosa condition. So if we talk about ridge form, we're back to the Phoenix article. Maxillary ridge vault form should be classified as follows: square to gently rounded, tapering or V-shaped, or flat, okay? And what we're looking at here is we want to look at horizontal surfaces that will act against forces that are placed in a vertical direction, okay? So if we've got this square or gently rounded palatal surface, that could provide a surface that could give us some resistance to occlusal forces, right? And again, the ridge form is really important here. If we've got a broad, flat ridge form that has good quality tissue over the top, then that provides a good amount of surface area for resistance to occlusal loading. If we've got skinny little ridges with knife-shaped bone underneath, that can be somewhat uncomfortable for the patient to chew against. All right. So let's look at some resorption patterns in the maxilla to determine, you know, what we potentially could be looking at. And this is from a classic article, Kaywood and Howell, from 1988, International Journal of Oral Maxillofacial Surgery. And this one is a classic because they looked at how, I think it was a radiographic study, how bone resorption patterns progress. And so if you look across the top, that's the anterior maxilla, and you can see when we look at the shape of the anterior maxilla and the resorption pattern, it starts off pretty skinny and it ends up even skinnier. So in terms of a broad horizontal surface for us to provide support against chewing forces, generally speaking, it's not great. It can be okay in certain circumstances. Some patients don't have significant resorption, but in a lot of patients, it can be quite poor, particularly in patients that have like a combination syndrome or some other feature like that. And then in the posterior maxilla, we can see, sorry if I go back there, in the posterior maxilla, we can see like the resorption pattern, the bone quality here is generally poor, it's less dense, it usually experiences significant resorption. You can end up with very little bone and tissue support in the posterior maxilla. So if we look at what happens when we put a denture in the mouth, this is from a mouse study. So somebody went and made dentures for mice, and so they took sections of tissue under load and not under load to see what the denture was doing. And the thing about this is the tissue is resilient. It's not fixed. It's not rigid. It has some kind of elasticity to it. And so it's kind of spongy in a lot of places. And that's kind of determines a couple of things. One would be how much support it can actually give to chewing forces, and how resistant it is to damage and future resorption. And there's a wide variation within the mouth as to what the types of thicknesses you can get. So we can get as small as 0.3 in masticatory mucosa, 0.3 millimeters to 6.7 millimeters in the maxillary tuberosities. So it's kind of important to have an idea of how thick the tissue is and what kind of quality tissue you have. And honestly, the best instrument that we have for that is a gloved finger. Just get a gloved finger in there and run it along the ridges and see, is that tissue firm and fixed and how compressible it is, and note any reactions that the patient might have to finger pressure. If they're uncomfortable, you know, that could be a sign that they're going to be uncomfortable with a denture. It's really kind of low tech, but very effective. So I thought I'd put in this kind of a humor break here. Like, this is like, I love the headlines from the tabloids in the UK. This is the headline: "Chew dirty rat. Filthy rodent stole grandmother's false teeth and hid them behind the fridge before her pet Jack Russell caught it and killed it." And there she is in the picture with her bleached denture and a dead rat. So like, it isn't just the mice in the lab that want the dentures, apparently, it's all the other ones too. So in terms of tissue, if we compare it to what a periodontal ligament does, the oral mucosa, it's lower in stiffness and it has the tendency to deform more easily, with a difference more than 3 times in the tissue displaceability relative to the PDL. Well, why is that important? We've already talked about patients that want to have a function that's equal to a natural tooth. It's just not possible when you're talking about a tissue supported prosthesis. And so if we talk about 3 times the amount, typical PDL movement is around 100 microns. So the average for tissue would probably be 300, but there's a wide variation. You know, it can range from very little, you know, probably 50 microns in certain tissue that's really thin, all the way up to, you know, probably millimeter or more in tissue that's flabby and mobile, you know. So it's important to characterize the quality of the tissue that you have to determine what kind of outcome you're going to get. So let's look at a picture here. This is a patient of mine that I saw early on in my prosthodontics residency. And you can see, you know, in the posterior, we've got nice tuberosities. They're fairly broad, even if they're a little bit short. The palatal area is fairly flat and broad, but it's not covered, you know, with this nice masticatory mucosa here. It doesn't exist here on the palate. And one thing you'll notice is in the anterior maxilla, we've got an epilus fissuratum here because the denture, the patient was wearing it for too long. We've got this severe resorption in the front. And I can tell you, my clinical examination, this was completely mobile here. You can see the incisive papilla. And the reason why this potentially happens is, you know, differentiation in resorption patterns, patient wearing a denture without having checkups for very long, and, you know, like maybe not having a nice balance in protrusion on a denture, or as the patient wore it, the teeth wore down and the occlusion destabilized. And so she got a lot of rubbing in the anterior. But this is something that we need to address before we make a new denture. You know, I can't say to the patient that I can comfortably make her a denture without having this resolved. And certainly there's not much I can do about the flabby ridge either. So, you know, if we're going to diagnose this as having what kind of an outcome it's going to have for anatomical expectation for support, it's going to be fairly poor. Okay, so these are the types of things that you want to look out for. Here's another case that I saw in residency. This actually happened to be a case I took to the board for my exam. So you can see in this case, the patient is presented with sore spots. He's got what I would call a minor to moderate palatal torus. And the real problem with tori is they're typically covered with really thin, poorly keratinized tissue. So they're not very resistant to chewing forces. And that's a problem because, you know, in a lot of texts will say that the palatal area is an area of secondary support for a denture. Some people even say it's primary support, but we'll talk about that later, which I think it is and which it isn't. But regardless, you have to be on the lookout for something like this because the tissue quality is poor. The torus itself isn't necessarily problematic. It's not going to be a problem for retention or stability, but it is a problem for support. So you've got to provide relief in this area for the denture. Sometimes it can mean significant adjustments, and it can mean an alteration in your impression technique and things like that. The other thing that you'll notice about this case is on the right side, the patient actually had a buccal advancement flap. He had a buccal fat pad advancement to close a persistent communication between his sinus and his mouth after a tooth extraction. So that basically has left us with almost no keratinized tissue on the buccal surface. So again, our support is going to be affected here because we only have the nicely keratinized tissue on the palatal side of this ridge. And the status of the ridge is pretty poor too because there's not a lot of bone on that side. It's mainly just soft tissue. So these are the types of things you want to be on the lookout for. So let's talk about support. This is a diagram from a textbook, and I couldn't actually find which textbook it is. It's actually, I found it in a thing called a Denture Green Book, which anybody who's in the Air Force will know about. It's kind of a literature review for dentures for prosthodontic residents in the Air Force. And this picture's in there, and it divides the support areas that we're looking for. And that these are the things we're going to be looking at when we look in the patient's mouth to assess the various qualities of tissue, the ridges and things like that we're going to need to resist these chewing forces. So if we break them up, this is areas of primary support, which would be the ridges and tuberosities. In fact, my preference is to keep this primary support area to the distal tuberosities. And mainly the reason for that is if you think about the way we set up denture occlusions, we typically will have the posterior teeth contacting in centric. So when the patient is just normally biting together, the front teeth aren't touching. So that means all of the load is happening in the posterior. So I tend to, personally, I deem the posterior areas more as primary support and the anterior ridges as secondary support. In this case, the secondary support, this author has deemed it to be the kind of Rugae area bilaterally. And this is, this person deemed it as secondary support without relief. You can just use it without altering the internal surface of the denture. This is secondary support with relief. And so they said that you may want to alter the internal surface of the denture so there's not as much load going into this area. And then we have the rugae and central ridge area that a lot of historical authors would have said, you know, you need to provide relief in this area again, because that suture area generally has really thin tissue over it and can get irritated quite easily. Not only that, but as the patient experiences resorption in the tuberosity areas bilaterally, you know, the denture is going to shift its support from those areas right down into that midline suture, which really doesn't resorb that much. So these are things you have to be aware of going forward with patients. In my opinion, the palatal area really isn't an area for secondary support at all, or primary support. The reason being, you know, the way that dentures are manufactured. So let's talk a little bit about stability now. So in terms of stability, really the thing you're looking at is ridge height and vestibule depth and peripheral muscle attachment. So you can see in this diagram, again from Kaywood and Howell, the tall ridges are important because height is what's going to resist horizontal displacement of the denture, okay? The other thing is these angles. You know, the more parallel these walls get together, the more resistant they are to those horizontal forces. And the reason why horizontal forces are important is because that sometimes is the chewing pattern of the patients. You know, if we have a bilaterally balanced denture and the patient is used to it, they'll often chew in those cyclic horizontal patterns. Some denture patients will chew vertically because that's the best way that they can control the stability of the dentures. They won't chew side to side because they don't have a lot of horizontal stability. But if you have these ridges, then we should be able to take advantage of them, okay? So then we go back to our maxillary ridge and vault form. The flat forms obviously are ideal. The tall tapering V-shape, yes, it's going to give us a little bit more height for horizontal resistance, but those tend to be very angled. And the other problem with that is stability somewhat is based upon the close adaptation of the denture to the tissue. And sometimes these vaulted palates are really difficult to get an accurate impression of because they're very fissured right up in that suture area. And so when we make the denture, it's hard to get it to adapt. And so we're not really taking all the advantage of that we could. And obviously the flat, the class 3 is a disaster because there's nothing to resist the horizontal displacement of the denture. So let's talk about probably what I think to be the most important feature of a maxillary denture diagnosis, and that's the ability to diagnose the potential for retention. So let's get rid of the complex features, okay, and we'll talk a bit about some of these contributing factors, okay? I even eliminated more. I was looking at this yesterday. I was like, all these things contribute, but there's really some critical elements that we need to look at. And a palatal throat form, border attachments, frenum attachments, and saliva quality and quantity. So in terms of retention, there's all these kind of complex terminology around it: adhesion, cohesion, interfacial, viscous tension, capillarity, oral and facial musculature, atmospheric pressure, and mechanical locking. These are all the theories of how a denture stays in place. And I'll go through the ones that I think are important and the ones that probably aren't as important. Interfacial, viscous tension, capillarity, and atmospheric pressure are in my belief, they're the most important ones to know about. So let's talk about the first one, the interfacial surface tension capillarity. So imagine 2 glass slides that you have and you put a drop of water between them, okay? As the glass slides come together, that water spreads out and the water will have an adhesion. Adhesion is the ability of the water to attract the surface of the glass to it. And it's going to have adhesion on both sides. And as it spreads out, it's going to have more surface area to adhere with, all right? So it's very difficult to pull these glass slides apart. Anybody who's done this, who's stuck 2 panes of glass together with water in between, it's tricky to get them out because the pressure in here, if we try and pull these apart, the force that's pulling the atmosphere in actually reduces pressure in that system and causes it to stick together. So if you can imagine one of these glass slabs as the denture surface and the other glass slab as the tissue surface, the more intimate a fit that you can get from your denture to your tissue, and the saliva obviously plays a role here, but the better that you're going to have that denture stick in place, okay? Obviously the saliva plays a role because its viscosity is directly linked to its ability to spread out between the denture, okay? And there's some other properties too. So like its viscosity would have a role to play in its own cohesion. So cohesion is the ability of an object to stick to itself. So we've got adhesion, cohesion, and those play a role in surface tension and capillarity, which is what we're talking about in terms of sticking the denture together. So why is it then, if we make a nicely fitting denture, that it could still lose retention? Well, there's a problem in that there's certain anatomical features that play a role. So we can see up here in the top left, the frena play a role, the buccal vestibules, although the musculature in the maxilla isn't as active, particularly in the posterior, in a way that would dislodge the denture. You know, if we're trying to make a nicely manufactured denture to adapt to all these tissues, and we have these features that come down here, and the patient can activate them when they're in function, that can actually break the seal. It can displace the denture, and then air can get in under the denture, and now we've lost our intimate fit. Okay, and so that's problematic. The other thing that we have with dentures that's problematic is our manufacturing processes. So this is a slide again from Dr. Phoenix right out of the Phillips Dental Materials text. And Dr. Phoenix did a study on denture-based manufacturing. You can see there's shrinkage in acrylic, and it shrinks away from the tissue, and it means that we're going to get a gap typically in the palatal area. So this is why we can't rely purely on the adhesion and capillarity and interfacial surface tension of saliva to hold a denture in place, because we find it difficult to get a denture to adapt properly to the tissue, which is why we come up with a thing called a posterior palatal seal, which is a modification to the denture. It's a non-anatomical feature that we use to counteract this shrinkage and regain an intimate contact with the tissue. Okay, we can just zoom in here. You can see here's heat-activated injection, heat-activated compression. Now, Dr. Phoenix found that the injection molded materials were less accurate than the heat-activated compression molded. And that kind of goes against the general consensus, I suppose, of what's out there in the market today. So how do we get around this fact that the denture shrinks and our impression materials shrink and we have inaccuracies? Well, what we want to achieve is a thing called peripheral seal. Okay, so some people might say, they might describe the action of a denture retaining into tissue as suction, but that's not actually what happens. What happens is the borders of the denture are extended into tissue that's displaceable. In other words, it can move. It's not like the masticatory mucosa that's on the ridges, but at the vestibule, as we all know, is kind of like a loose bit of tissue, and it can actually be pushed. And so if we can push on that tissue, then we can always maintain an intimate contact with those particular areas. And that means then the periphery of the denture is sealed to air and other things going under the denture and causing a loss of that interface. And so the way that this works is, we put the border in and it pushes on that tissue. So the goal for us when we're making a denture is to extend the borders of the denture to displaceable tissue and then to displace that tissue. And that's what we do when we're border molding. We don't and we border mold to the physiologic limit. So we put green stick or whatever, however you choose to do your border molding. Some people will use PVS or other materials. You put it up into that vestibule on your custom tray, and it occupies a space. It actually pushes the tissue out of the way. And this is it's kind of an art form determining how far you're able to push on that tissue before it irritates the patient or before the patient's muscle action is able to dislodge the denture. And that's going to be different for every patient. Some patients will be able to mold the borders of the denture themselves because they've got good control over their muscles, and their muscles are strong and they're well used and they're used to wearing a denture. Other patients will need a little bit of help, so you'll have to get your fingers in there when you're border molding. The tricky part about peripheral seal happens in the palatal area. Probably most of us know this already, that the posterior palatal seal is a tricky thing to achieve sometimes. And again, I think a lot of that is due to our own ability with diagnosis, because not every posterior palatal seal is going to actually be achievable. So this is the classical literature from House. We talk about House's palatal throw form, and if you talk to different people, their understanding of this kind of depends on where they went to dental school and who the prosthodontists were in their school, and everybody has their own interpretation of this. Even when you read House's own writings on this, it's kind of confusing. This is from the Phoenix and Engelmeyer, or Engelmeyer and Phoenix article, a review article, where they have these simple line drawings to show us what we're looking at, but even that's confusing. So if you listen to the description, the class 1 is large and normal in form. It's 5 to 12 millimeters distal to a line drawn across the distal edge of the tuberosities. That's an arbitrary line. It's not an anatomical feature. It's just we decide to put it there, and then we see where the vibrating line is, right, relative to that House's line. And then we say, oh, it's a good palatal throw form or it's a bad palatal throw form. Well, there's a lot of nuance to this. It actually leaves out a lot. And other interpretations talk about the downturn of the palatal curtain. Well, honestly, I have a difficulty figuring out what that is a lot of the time, and it's not entirely relevant to me. if you look at this picture, the biggest problem with a picture like this is it's static. It makes us think that House's palatal throat form is just there and it doesn't move. But we all know the soft palate moves like crazy. You know, it's designed to move. It's designed to close the nasopharynx when we're swallowing. It's functional and speaking, you know, so that we don't have that hypernasal speech. It closes off the nasal cavity when we talk. So it's designed to move, and this is a static image. And so it can elicit a lot of confusion as to where we want to put our palatal seal. So the classic teaching, we look at something like this. There's the line. So where's the vibrating line now? I've heard a lot of different people do the Valsalva maneuver to get them to inflate the soft palate, and that'll determine the junction between the soft palate and the firm fixed tissue of the hard palate. Not unreasonable, but not always accurate. And then how to determine the vibrating line. There's tons of different ways to do that, and not all of them are effective. So let's talk a little bit more about palatal throat form, because in my opinion, it's actually the most important factor for determining the anatomical expectation for outcome of maxillary complete denture. So I was lucky enough to learn from my mentor who went to University of Southern California in the 70s to do his prosthodontics residency, and he studied under some real denture greats like Levin and Sosin. So Dr. Haney talks about this Sosin interpretation of House's palatal throat form. And honestly, until I'd heard it described this way, I never really understood it. And I hope that my drawings can convey what they mean. If not, we'll talk about it afterwards in the QA, because this is pretty critical. So let's look at about the palate moves, okay? I'm gonna go back and do that again. So how do I get the patient to do this repeatedly and predictably? The sound that we ask them to make is a short, sharp ah, ah, ah. It's not ah, and it's not anything else other than that. It's just ah, ah, ah. If you get them to make a short, sharp ah, what they're doing is the palate is moving up to close the nasopharynx so that they don't have hypernasal speech when they make their A sound. And if it's short and sharp, the palate will drop back down right after the sound is made. So you can see a really distinct vibration. So you'll see, now if we see that in this particular patient, this triangular area here represents the bone, and this is the attached tissue above the bone of the hard palate. And so if the patient moves like that, where they have this area at the back that just moves like that, we can have, this area represents an area of function that we can't put a posterior palatal seal on, because if we do, every time the patient says ah, they will lose seal. This area in the anterior represents firm, fixed, usually fairly well keratinized tissue that isn't able to be functional. You can't displace it. If you put your posterior palatal seal here, what will happen is that tissue will adapt over time. You know, it's compressible, the edema will be pushed out of it, it will adapt over time, and as it adapts, then eventually the seal will be lost. But this green band in the middle represents an area of soft palate that's displaceable but not functional. In other words, the patient doesn't move it when they're speaking, swallowing, et cetera, but we can actually push on this area with our denture and create a seal. So we can put our palatal seal in here and push this little band of tissue up. And usually it's in a House's 1, it's usually pretty wide, so we don't have to be terribly precise about where we put it or what kind of design we use, as long as we put it into that area. Now, we also don't want to extend back into this area too far, because as this moves, it's going to rub off the distal extension of the denture and cause the patient discomfort. They'll get some ulceration. So let's look at a class 2. So a class 2, we see a little bit more movement relative to where the soft hard palate junction is, and we usually will have this skinny little band of tissue that's displaceable, and it's oftentimes really hard to distinguish between a class 2 and a class 1 when you're looking at it in the mouth, because the band of non-mobile tissue is fairly skinny. So these are tricky. You have to be somewhat precise with your placement of your posterior palatal seal. And I think some people would advocate border molding a functional seal. In other words, putting your green stick on your custom tray and testing it out when you're doing your impression. I'm not a huge fan of that one, because I find green stick can be displaced. And then when you make your impression, the displacement is usually, the tray is displaced enough that you lose your posterior palatal seal area in your impression. So I like to mark it, transfer it to the impression, transfer it to the cast, and then cut it into the cast by hand. But what I will do is I'll test it out during my base phases. So I'll make a denture base on that cast that I can test my posterior palatal seal and confirm it, right? And then, so this is the class 2, a lot of movement. And then the class 3, a lot of movement. We'll even see movement in front of that imaginary line joining the tuberosities, anterior to the junction of the hard and soft palate, there can be functional tissue that goes that far forward. And so when we talk about the placement of our posterior palatal seal, it's super tricky. Even House and other authors say it's not impossible, it's just difficult. And really we should be talking about probably bead lines for these patients, or very skinny butterflies. So a butterfly is just a bulbous, it's got two little bulges on either side of the posterior palatal seal area. And so it just requires precise placement and confirmation when you're getting to the later stages of your denture manufacture. But as a diagnostic feature, you can confidently say that if you have a House's class 3, that you are going to have a reduced expectation for outcome. So the prognosis is going to be poorer. So how do we determine that? Well, this is an old article from Hardy and Kapoor, posterior border seal. And the only way really to test it is to palpate it. So I like to use, this is a T-burnisher, which is something we probably don't have lying around most of our clinics, but a mirror, turn the mirror on its side. And what you do is you just hold the mirror up against the edge of the mirror, up against the palatal tissue. And you get the patient to say, if you're holding the mirror still and the tissue moves away from the mirror, you're too far posterior. You need to move the mirror anterior until the tissue doesn't move away from the mirror edge. And then what you need to do anterior to that is compress the tissue, see how displaceable it is, and see how much it rebounds, see how elastic it is. If it's super thin and tightly bound to the bone, you know that you're not going to be able to extend your palatal seal area that far forward. So it's going to be tricky to do that. So again, this is about palpation. A lot of what we do in denture diagnosis is about that. And just check time here. We're going okay. Anatomical expectation for outcome, we're going to move on to the mandible, and it's an entirely different animal, the mandible. It's way more difficult to make a mandibular complete than it is a maxillary complete. And it's mainly due to the anatomy that you're presented with mandibular patients. And the number one difference is the tongue, and we'll talk about that. So let's talk about support. All these complicated features, let's get them down to the ones that are most important. So ridge form, tori, bone quality and quantity, mucosal thickness, and mucosa condition. Again, we go back to ridge forms from the original article that I like to cite. Inverted U-shaped is not a very common presentation. So that guy at the top, not a hugely common presentation in mandibular completes. The shortened version, that does happen from time to time. I see a lot of this inverted W, where we have resorption down the central area of the alveolus, or the short inverted V, very flat. I think we've all seen these. Also, that kind of gets neglected, or we think is maybe a bit easier to work with, is these tall, thin inverted Vs. This is probably the most common, the knife ridge in the anterior, and the short U or the inverted W in the posterior is most common. These are really tricky to make dentures for. So let's have a look. Again, resorption patterns in the mandible, Kaywood and Howell, classic article. Look at how skinny it gets in the anterior mandible. How are you supposed to make a denture fit that? How are you supposed to say to a patient, no, yeah, you can be comfortable to chew on this skinny little knife ridge? In fact, there's a lot of patients that we probably should be looking at this and saying, let's do some recontouring for you. Or certainly let's talk about implants. Let's have that conversation. Because imagine you have gingiva on top of this and you chew on those gingiva. They're getting pinched by that skinny little piece of bone, and it's very uncomfortable for some patients. And it's not really a reasonable expectation for them to adapt to that. They may not. So it's certainly something to be aware of. And again, the resorption patterns in the mandible, you can see how quickly we go from a nice alveolus. This even would be okay. This is difficult. This is basically, these are almost impossible. The reason why these are problematic is because it's not just about the shape. If it was just the shape, we could say, well, we have a broad area that we can rest the denture on. But the problem with these is the tissue over them changes too, from highly keratinized, tightly bound tissue to sometimes poorly keratinized, loosely bound tissue, which is never good to be chewing on. It's just not resistant to those forces. So yeah, we're going to get a closer look at these guys. This little skinny thing in the anterior, how am I supposed to do that? How am I supposed to make a denture to fit that? It's really, really difficult. And to get it to stay in because as this resorption pattern happens, the mentalis muscle doesn't move its attachment. And so it's going to have a lot of activity here. Again, in the mandible, these inverted shapes are extraordinarily difficult and easy to misdiagnose. Like sometimes you'll think the center of your ridge is lying on here or on here, and instead the center of the ridge is right here, which can affect where you put your teeth. So let's have a look at a couple of pictures. This is another one of my patients. He presented like this, having worn a denture for many years and struggled with it. And the problem with the tori is that they have really thin tissue over them. They're just impossible to chew against. But he has all this lovely, densely keratinized, tightly bound tissue on the buccal surfaces here and here. He's got a skinny knife ridge in the anterior, high frenal attachment. So in terms of support, if we're looking at this, it's good in the posterior areas where we might want more. It's very poor up here in the premolar region because we're not going to be able to load too much on these. And also they're very high, so it'll affect our horizontal resistance to our stability. So we have to get rid of them. So let's look at where our areas of primary support are in the mandible. Buccal shelves. So the thing we want to avoid really is that central ridge crest, because a lot of the patients it's knife edge, so we want to have some relief in those areas. Secondary support is actually the slopes of the ridges. So if you've got a ridge that's nicely sloped on either side, you can actually recruit some support from those slopes and avoid the crest of the ridge. But most of the support you're going to try and recruit is from the buccal shelves. And again, that's quite tricky because not every patient will have a buccal shelf. Oftentimes they're very narrow and covered with tissue that's really poor condition. The other area that some people might hear mentioned as a primary support area is the retromolar pads because they don't resorb. That is true for some patients. The retromolar pad is a nice area for primary support because it's tightly bound and it's very well keratinized. But you can see in some patients like here, we've made a diagnostic impression and the tissue, there's a fold on the tissue. And that means that the algin that I used here actually pushed the retromolar pad out of the way. So I wouldn't be fully confident using that area as an area of primary support, but we certainly have to make our denture cover that for lots of reasons, not least of which if we want to at least attempt to get some retention, we'll have to cover those and we'll talk about that in a minute. So you can see I've drawn a line here where I'm going to have some relief. This patient has had some implants, so I'm going to make some relief in my impression tray in this area. And I'm aiming to have some relief over that knife ridge in my definitive prosthesis. I want to recruit these areas, these slopes of the ridges for denture support because it'll make it more comfortable for the patient to chew. Talk about mandibular stability. Again, we'll eliminate the complicated ones. So ridge form, which is obvious. I'm not going to go too much into that because we talked about it in the maxilla. It's just about ridge height and the keratinized tissue. Lateral throat form, tongue size, and tongue position. So lateral throat form, something that not a lot of people will have heard from. It's come up. It was first talked about by a guy called Ewell Neal, who was a very successful removable prosthodontist in the 20s and 30s. And a lot of his work has been quoted, misquoted, and maybe even plagiarized. So the houses are the house's personality types. House maybe got them from Ewell Neal. And I was reading about him recently, and he used to do seminars in New York where he had 500 dentists, in a near riot to sign up to his courses because he talked about how to make a suction effective denture. And the key to it was the extension of the dentures. So, if we talk about peripheral seal necessitating us extending the denture onto displaceable tissue and then displacing that tissue, then we're going to want to have these lingual flanges extended into a position where they're actually contacting tissue. And that's really, really tricky. And particularly tricky if you've got a short retromylohyoid area. That's that area in here, behind the mylohyoid, which is here. It dips down and extends back behind the retromolar pad. A lot of patients won't tolerate a denture extension back here, but it's actually fairly critical for not just stability, which is, we have this vertical height that we can recruit here that stops the denture fishtailing, but also plays a role in retention and peripheral seal. All right. So this is what the lateral throat form looks like. I found this in a nice Indian Journal article that reviews this concept. And when you pull the tongue out of the way, you can see this dip down in here. We want the denture to extend there, but we want to be able to displace this tissue here. The big problem with displacing things in this area is this area moves, and I'll show you what that means in a minute. And so the most important thing is retention, and it's really, really difficult to achieve in a mandibular denture, and it's mainly because of the tongue, because it moves around on the floor of the mouth, okay? So we have all these features that can affect the retention of a mandibular denture. We've frenal attachments, we've muscle activity from the mentalis and the buccinator, we've got high lingual attachments onto the genial tubercles when the mandibular denture, when the alveolus resorbs, and all those things are acting against the denture staying in. And basically the only things that we can rely on to keep the denture in, apart from the ones we talked about before, the adhesion of saliva and the close adaptation, is the ability of the tongue to sit on that denture, okay, to sit on top of it and keep it in place. So it's really the patient that kind of learns how to control it. So this is the bane of my existence, is the gigantic wandering tongue. And it's not just with denture patients. I'm sure we've all seen patients that we're trying to treat restoratively that their tongue just is out of control. But like in a denture patient, it's particularly important because the tongue is what controls the bottom denture. And this is something that I suffered with for a long time with mandibular dentures. You know, when I was in practice, I used to just tell patients, your bottom denture just is never going to work for you. It's never going to fit. It just isn't. And that is actually true for a large proportion of mandibular denture patients. But there is a small group of patients that will be able to tolerate a mandibular denture and they will be able to control it. So the critical diagnostic is the tongue position. So this is Wright, another classic writer. So the normal position, the tongue fills the floor of the mouth, is confined by the mandibular teeth. So when you look in, if you get the patient to open just a little bit, their tongue will be sitting in the floor of their mouth and touching all the lingual surfaces of the teeth and nice and relaxed. It just sits there. And as they open and close, it stays there. And some patients who get dentures when they're young, they have the neuroplasticity to adapt and they learn how to control the denture this way with their tongue. Okay. The retracted position, honestly, I grouped the two together. There is a subtle difference that's important. Class 1, the tongue is retracted, the floor of the mouth is pulled downwards and it's exposed back to the molar area. So you look in the patient's mouth and their tongue is like a ball in the back of their mouth. And the floor of the mouth is actually moves downward. So the volume increases in the floor of the mouth space. And that's important because, again, we're talking about areas that are functional. How are we supposed to extend a denture border into that area and displace tissue if it's going to move every time the patient moves their tongue? The class 2 retracted position, the tongue is pulled backwards and it kind of sticks upward a little bit. The apex is pulled into the body of the tongue. Again, like tongue looks like a ball. The lateral borders rest above the mandibular occlusal plane and the floor of the mouth is raised and tense. So like everything just comes up and you try and, even if you try and palpate the floor of the mouth, it's like tense and firm. And I think some patients get this way after wearing dentures. Some patients get this way because you'll see them when you're trying to do restorative work, their tongue will ball up because they're afraid of inhaling water or whatever. They're protecting their airway. And there is a certain degree of this that can be trainable. Some patients can be taught to get their tongue to behave a little bit. It's tricky and time consuming. And actually speech and language therapists may be more effective at it than a dentist. So, but it's absolutely critical for the outcome of denture. So what does this mean? This is straight out of the Netter textbook. A lot of people will recognize this because it's got some fantastic diagrams, but let's just zoom in on the picture here. And as the tongue moves up, the floor of the mouth moves down. So now imagine you've got a stable denture flange and the floor of the mouth is going to move away from it every time the patient lifts their tongue and you lose seal. It's basically almost impossible to make a denture that's going to seal in that patient. Thankfully, not too many patients have that issue where the floor of the mouth, the volume of the space under their increased sublingual space increases, but it can happen. And so, you know, it's something to be aware of. You saw that picture that I showed with the mirror in the mouth, and that's actually how you diagnose a lateral throat form. You get the patient to open, get the patient to try and relax their tongue as much as possible, and you put the mirror down beside the tongue. If the mirror disappears, they've got a good lateral throat form. If you can see all of the mirror, then it's a class 3 or a poor lateral throat form. Then what I will also get them to do is just move their tongue. And if they put the tip of their tongue up to the roof of their mouth and the mirror then disappears, then I know I'm going to have probably a bit of an issue. And if I get them to move their tongue up to the roof of the mouth and the floor of the mouth moves up and pushes the mirror out, I also know I'm going to have a problem. And so this is going to be tricky denture to make. So this is the opposite one. Tongue moves up, space gets smaller. The patient is going to constantly want to be pushing that denture out of their mouth with their tongue unconsciously. It's just a thing that happens. And so this is it's a continuous issue with patients, you know, having that conversation with them, getting them to learn how to control their tongue. So this is a good form that I use for my patients. It's fairly concise. It has all the various features that contribute to a denture diagnosis or an anatomical expectation. You'll notice that the next thing that you have to look at is if the patient presents with existing dentures and they don't like them, you have to put the patient's dentures in their mouth and evaluate the dentures for support, stability, and retention. Now what you do then is you come back and you look at your anatomical expectation for outcome for support, stability, and retention based on what you see in their anatomy and compare it to what they came in with their dentures. Because some patients will come in and their dentures will meet their anatomical expectation. And what that means is there's no way you're going to improve on it. And you should tell the patient, I can't do any better than what you've got. This is critical because we've all had the patient with the bag of dentures coming in or complaining about their previous dentist. and you look at the dentures or worse, I've done it, not looked at the dentures and gone ahead and made a new set, and we're back at square one. The patient says the dentures are horrible. So this is how you're going to save yourself, is to have an appropriate diagnosis and look at what the patient has and see, can you improve on it? Some patients you will be able to improve on it, or you might get you say to them, I can get a small improvement. For me, what I've found is I'm almost always able to get a good improvement for the maxilla and very rarely able to improve in the mandible, which is why we have, things like the McGill consensus where they recommended 2 mandibular implants for mandibular edentulous patients. And I actually think it probably should be more like 4 for many patients. But so always look at the existing dentures if they have them. Other patients, you'll be coming in and you'll be looking at them in the context of terminal dentition, and you'll want to look at their diagnosis for that too. So then you write an anatomical expectation. Is the support going to be good, fair, poor? Stability going to be good, fair, poor? Retention, good, fair, poor? And then an overall assessment. And then you can tell the patient, look, I understand that you don't like your dentures, but I'm just not going to be able to do better. Or I understand you don't like your dentures. They're worn out, they're beat up. You need a new set. This is how we're going to do it. There are some other ways that you can use to protect yourself, in the case of a patient who has unrealistic expectation, but you haven't elucidated exactly what their expectations are. And like my favorite version of that is what's called the pound Branchy technique, or the Turbyfill technique. A lot of you may have had the experience of learning from Dr. Turbyfill. And he basically makes a set of temporary dentures as a diagnostic, like a treatment denture. And if the patient can't get used to the treatment denture, then you don't move forward with definitive treatment. It's a wonderful way to treat difficult denture patients. And that's my favorite way with a patient who comes in who's got the bag of dentures, or who complains about the previous dentist, or who I think I can get a small improvement in, but I'm worried that they're going to have an adverse reaction to my treatment. So I'm not going to talk too much about the Turbyfill technique, but I think you can look it up, and there's DVDs. American Academy of Restorative Dentistry has a DVD series. It's really good. So I've kind of boiled it down into like even less features than Dr. Haney's form. I tried to get, down to like 6. We talk about, I think, the 2 most important features you can look at if you just had 5 minutes to look in the patient's mouth: House's palatal throat form and Wright's tongue posture. They're going to have the biggest impact on the outcome of treatment. And then the other things, if you've got more time to look at, you can look at those. So vertical stress bearing, and you'll notice I kind of have them in order of importance, and they're different in the maxilla and the mandible. Good, fair, poor, peripheral muscle attachments, vertical stress bearing, Neal's lateral throat form in the mandible. And then I haven't really talked about saliva. There's a good article, Niedermeyer and Kramer talk about salivary secretion. Really, we only have good evidence for what happens in the maxilla. If you've got a well-sealed denture, it's the mucinous saliva from the palatal minor glands that actually contribute a lot to retention of a maxillary complete denture. But in the mandible, because of gravity, usually you have whole saliva. It's mixed between the major and minor salivary glands, and more serous saliva generally means less retention. It's thinner, and it doesn't have, as much protein content in it, so it's not as adhesive. But what you want to look out for is you don't want to have super dry or totally hypersalivators. Like, you don't want to have a ton of saliva because the denture is just going to float in the mandible, and the maxilla is going to be constantly displaced by saliva. And you might have some patients who have a gag reflex who will have this kind of salivary response too. So what you're looking out for is I got this backwards on this right-hand side, is mucinous saliva for both the maxilla and mandible as much as you can. And again, it's hard to qualitatively analyze saliva. You got to be quick, or not quick, but you kind of just have a look in and get your best judgment and talk to the patient and see if they're feeling dry. So let's move on to some cases here, for practice, and run through how I kind of look at this. This is Bob. He's again, another denture patient of mine. Lovely gentleman, came in pretty much in a different personality. And the reason why I know that is because he kept saying to me, you're never going to make any money as a prosthodontist if you take this long to make dentures. So like, that tells me straight away that he's indifferent, but absolutely lovely man, got along great. And I was able to treat him to his expectation. He was happy with the outcome. But the first thing we look at here, he's slightly open, and you can see where his tongue is. It's not balled up at the back of his mouth. It's kind of sitting against the backs of the front, the mandibular anteriors. It is large, and that's common for denture wearers. Their tongue grows over time because it's not as confined, because they're not wearing the denture at nighttime, or at least shouldn't be. So a third of their life, their tongue is unconfined, so it tends to grow. So the first thing I would say is his right tongue posture is normal. And this is actually, in my experience, not common. I think the retruded tongue postures are more common. So we look at his maxillary ridge. We can see he's got a square palatal vault, which is nice. He's got broad, tall U-shaped ridges. He's got some mild stomatitis because his previous denture, he's been wearing it for years, I think 30 years when he came to see me. And he, you know, it just was beat up, and the tissue gets like that after a while. Firm fixed mucosa, and he has a House's palatal throat form too, which you can't see in the photo. You know, you can't diagnose this from a static picture, but, you know, overall, I would say his anatomical expectation for support is good. You know, he's got this firm fixed tissue. Okay, we need to do a little bit of tissue conditioning, but he's got an abundance of tissue. His ridge form is good, and so good for support. And, you know, his palatal throat form is intermediate, so I think retention is good, and stability also good because of the ridge form. We look at the mandible, it's an entirely different story. This is what we're talking about. He's got severe resorption in the mandible. He's got poorly keratinized narrow buccal shells back here. He's got a high active mentalis muscle. That's going to work to dislodge the denture. He's got high genial tubercles, so that is where the tongue attached. And again, this is generally, if it's not very active, it doesn't like having a denture being rested on it. These can get quite sore from function. He's got a normal tongue posture and a Neal's lateral throat form too. So the anatomical expectation for support is poor, for stability is poor, and for retention is poor. He doesn't have any good defined features. So we talked about implants with him, and he went some way towards doing it, and then pulled out at the last minute. He was happy enough with his existing dentures, with the ones I made him. So if we look at Bob, his overall, he's got some, his maxilla, I think overall pretty good. I would say he's a little bit dry as well. So I'd say overall probably fair expectation, anatomical expectation for outcome in the maxilla. And in the mandible, it's poor, even though he's got a normal tongue posture. These other factors outweigh that one. So let's look at, then we put his existing dentures in the mouth. You can see severe wear, they're discolored. He's not in balanced occlusion anymore. He's got no support on this side. So I think we can probably improve. When I put these dentures in as well, they were unstable. So I thought, even though his anatomical expectation is poor, I think, and I thought that I could get a better outcome for him. And ultimately we did. So even if you have a poor expectation, it can be worse than poor with the existing dentures. This is another patient of mine, Al, and we saw him already. Again, look at the tongue posture here. It's slightly forward. Now, the other thing is the tip of the tongue curls down here, and Al actually had a little bit of a lisp, and I think it's something to do with his tongue and how it behaves. I'm not entirely certain how all that works, but I know his tongue posture, I'd consider it normal because it's not balled up at the back of the mouth. We look at his maxillary arch, you can see a shallow palatal vault. He's got these really short, flat U-shaped ridges in the posterior where we're going to hopefully recruit our primary support. He's got some firm fixed mucosa. Like this looks like it could be wobbly if you put your fingers on it, but it was actually firm. You can see how severe the resorption is here because the first rugae is on the top of the ridge. So he's had significant buccal resorption here and probably, you know, vertical resorption too. His House's palatal throat form was actually a 3. So it was really, and it looks like he's got a lot of tissue here. Like if you took a normal line here from the hamular notches, it looks like he's got a lot of tissue back here, but the problem was it was highly active tissue. It was very mobile. So it was difficult for me to place a posterior palatal seal. And I remember with Al, I actually had to take a second impression for him in his denture base. So this is Al that I showed you earlier with his tuberosities. So if we look here, some of the things we can look at: broad and tall inverted U-shaped ridges in the posterior, moderately broad buccal shells with good keratinization. So we think we can support a denture there. A low muscle and frenal attachments in the lingual and the facial. He's got a normal tongue posture, and he's got a Neal's lateral throat form too. He has a super deep area here, and the floor of the mouth wasn't very mobile, so that was good. So we sent him off for surgery, and this is what he came back with. So now we have to redo his diagnosis. Now he has narrow inverted U-shaped ridges, so he's lost some bone, and that's not uncommon. You know, every time you raise a flap, you're going to lose a little bit of bone. He's got moderately broad buccal shells with good keratinization. He's got a high lingual frenal attachment. This was as a result of the flap being placed in a certain position. In order to stabilize the flap, a particular suturing technique was used, and it resulted in the attachment of the tongue migrating higher up on the ridge. We debated whether we were going to send him back for more surgery. What I decided to do is I'd go ahead with impressions, and that we do a functional impression technique here, and then test it out and see if he was having some pain or discomfort, we'd send him back to have the attachment moved, and then we just reline the denture. But in the end, he was happy enough and he didn't have too much frictional discomfort. But so anatomical expectation here for support is fair. It's poor in the anterior, I think fair to good in the posterior. Stability, I think fair. The ridges are reasonably short, even though he's got, you know, deep vestibules here. This tongue attachment could destabilize the denture a little bit. And his anatomical expectation for retention was good because he's got a normal tongue posture and he's got a good lateral throat form. And he tolerated the extension of the denture well into the sublingual space. So let's look at him overall. So House's palatal throat form 3, that was poor. So his expectation for retention is poor. If you've got a difficult House's palatal throat form, it kind of supersedes everything else. Vertical stress bearing is fair. So support in the maxilla, probably fair. And stability, fair. So overall expectation, somewhere between poor and fair for the maxilla. And I think somewhere between fair and good for the mandible, which is rare. It's usually the other way around. It's not often you get a mandibular denture that you think you can get a good outcome with. And he had good saliva, so I was happy enough with that. So let's look at Art now. I'm going to throw a little bit of a curveball. So Art presented like this. He's not actually a dentulous. So how do we make a diagnosis here? Why are we even thinking about this? Well, it's very important when you have a patient who presents with a potential need for edentulation that you have to make a denture diagnosis for them to determine their likely anatomical outcome or expectation for outcome, because it could steer your treatment recommendation one way or another. For instance, if I saw Art and I thought he had a poor anatomical expectation for outcome for a maxillary mandibular denture, I'm going to be having a conversation with him and probably steering him a little bit more towards implants. I mean, we're always going to have that conversation when a patient comes in like this, but at least we can have some evidentiary support. We can take photographs and explain to the patient why it is that implants might be important for them. You know, it's very easy to say, well, you're going to lose all your teeth, you're better off having some implants. It's much better to say you're better off having some implants, and here's the reasons why. And have them patient specific and not generalized in that, you know, an implant retained prosthesis is superior to an edentulous removable prosthesis. That's not always the case. You know, I've found some situations where a removable prosthesis actually was better for the patient because they just weren't able to have implants. So this is the problem with Art. He's got this big misbehaving tongue. So I already know his anatomical expectation for outcome in the mandible is going to be probably poor, even though he's got tall ridges and he's got an abundance of bone. Let's look at the maxilla here. We can see like just these crazy tuberosities. Art had this version of like a combination syndrome, even though he had teeth. His anterior teeth were probably intruded and heavily worn. Posterior teeth had lost their stops and super erupted. So he kind of got this tuberosity hypertrophy there. And like, I can't even get the tuberosities into the photo because the mirror wouldn't go back far enough. They're gigantic. And you can see the soft palate comes this far forward. And in fact, in Art, he had a class 3 House's form where his vibrating line was here, that far forward. So that's going to be a tricky one to do. In the mandible, you know, nothing spectacular to see here apart from he's got some minor tori. So if we are considering a denture and we're going to edentulate him, we should probably think about removing those at the same time. So hopefully it's somewhat clear, you know, think about things in terms of support, stability, and retention. If you can boil that down, you can do a fairly quick exam for a patient and tell them what your expectations are for them and compare them to existing prostheses is important. So let's move on to how a denture can help us with aesthetics, or what dentures have taught us about aesthetics. I think many of you would have heard Dr. Robbins today. Like, I don't think I've heard anybody speak about this topic in a more concise and understandable way than Dr. Robbins. Like, he's a masterful speaker. And, you know, I've been lucky to see him a number of times because he's obviously a San Antonio guy, and Dr. Rouse too. But absolutely brilliant when it comes to this stuff, and actually probably will change how you think about diagnosis for aesthetic cases, or just in general. If you're talking about rehabs and dentures, this has a role to play. And a lot of what they talk about in the book comes from our understanding of denture aesthetics. So the big things we look at in denture aesthetics: tooth position, how much tooth we're going to show, the occlusal plane, the smile curves, and the buccal corridor. this is the article that is most important when we're deciding about how to establish an occlusal plane, how to position. So we start everything in dentistry with the central incisors. And Dr. Spears talked about this, and Dr. Robbins talks about it, Dr. Coy's, everybody. This is how you do it. You start with the central incisors, and this is the article that tells us where to put them. It's based on how the lip dynamics. So how the lip moves, where it is at rest, and where it is when the patient smiles, and how much tooth they're going to show. And this is Vig and Brundo, and it basically kind of tells us a couple of things. It tells us, this one table tells us that the shorter the patient's lip, the more incisor reveal they have. And in the second table, it tells us that the older the patient is, the more their their oral orifice actually moves. It shifts from closer to their nose to closer to their chin as they get older. And it's basically, you gain 1 millimeter in maxillary lip length for every decade after 40. And so when you're, at 40, the average incisor reveal is about 1 millimeter. And then when you get to 50, it's 1/2, and 60, it's like you shouldn't be showing any. So then when you set up, when you do a tooth setup for a denture, or when you're planning a rehab, you put the central incisal edge where the lip tells you to put the central incisal edge. And the height of the incisor is usually governed by how much lip travel you have and where you want to place the gingival zenith, because we don't really want to see too much pink when the patient smiles. So this is a patient of mine, this is Sylvia, and this is the denture that she presented with. And we can see a couple of things in this image. So if I go back to her lip isn't quite at rest in this photo. And we'll see later on what her resting lip looks like. And it's an easy mistake to make, and it's one that I made. You can see just a little bit of an edge of the incisor there. And then when she smiles, she reveals pretty much all the incisors. But those incisors have been worn, so they were a lot longer when she got this denture first. We can also see her buccal corda, she kind of has a lot of negative space there when she smiles, which, to be honest, it doesn't particularly bother me. In some patients, it can look aesthetic. Like the very first patient I showed you, she had a lot of buccal corda, but I think it looked pretty natural for her to have that. So when we get to doing her final setup, this is her lip actually at rest, and she might even be a little bit active here. And you can't see the incisal edge is basically at the level of the lip. And then when she smiles, she doesn't reveal a lot of incisor. Now, a lot of different people would have set this tooth set up differently. But I like when I set my teeth up for them to follow the curvature of the lower lip as much as possible. And you can see in her previous photo, she kind of has this somewhat negative smile line of her incisal edges. It doesn't follow the curvature of the lower lip. The occlusal plane doesn't taper upwards with the curvature of the lip either. So that will have a role to play. And so I just think she liked it. I liked it. If I'm being hypercritical, we maybe could have set up the incisors a little bit lower to show a little bit more, but in the end, she was happy with it, and I was okay with it too. The other thing we want to look at, so one, if we want to set up a plane, a reference plane for anything, we talk about the occlusal plane. In order to do that, you need 3 points in space. So we started off with our first point, which is the incisal edge position. And now we need to figure out our other 2 points. And if we're going to do that, we need to look at this in 2 planes. So this is Art again. And I've put a Fox's plane in his mouth. And you can see what I'm lining up here is with his interpupillary line. There's a lot of different horizontal reference lines that we can use. But the easiest one, the quickest one, if you're looking for a fairly quick diagnosis early on, is interpupillary. Now, not everybody's going to have a perfectly symmetrical set of pupils. Sometimes one is lower than the other. And so the other way of doing this is looking at the midline of the face and taking a perpendicular. You can look at intercommissure lines with the patient lips at rest. However you decide to do it, you need a reference line that's reasonably aesthetic. You can see here, Art's occlusal plane is way off. It's actually like 6 to 8 degrees. I measured this morning. And then we need to look at it from the side, and the reference plane that we commonly cite is called Camper's plane. And the definition of that in the glossary prosthodontic terms says that it's from the superior aspect of the tragus of the ear, which is this, to the inferior, well, I think it's the inferior of the ala of the nose, but some people will define it as the greatest curvature of the ala. So if you drew a tangent to the ala, you'd put it through the middle of that. But honestly, I find that to be sometimes not a very aesthetic occlusal plane. It sometimes can be a little bit too steep for a lot of patients. And there's some research to show that the best occlusal plane isn't actually that. Some people will put the occlusal plane here. They'll start from the inferior of the tragus to the superior of the ala. Now that doesn't really follow Camper's original definition. But what I'm trying to say is this isn't a firm fixed definition. There is a range within which you can operate to set an aesthetic occlusal plane. And so here's middle to middle, and Art isn't actually too far off it on this right side. If we look at him on the other side, he's going to be a little bit different. The other thing that I'll point out here is like Art's head is pretty level here, and his occlusal plane isn't too far off level. I have tilted the photograph to make him level, but there are other people that will say that you can set your occlusal plane based on natural head position, which is kind of confusing. But I just want to look at this little video from Mercedes-Benz. Hopefully it plays. I don't know if there's any sound, but you'll get the idea from the picture. So they take the chicken and they move the chicken around, but the chicken's head doesn't move. It's amazing. Yeah, so anyway, the chicken has this positioning system for their head. And we humans have one too. It's called the balance system of the ear. And so we know how to position our head in space. We have that innate sense of proprioception, okay? And so some people like this idea of a natural head position. This is from Zirconzan, their face hunter technology or their plane finder technology. The idea is the patient looks in a mirror at their own eyes and we have this natural leveling ability. Now, the only problem I can see with that is if you set the occlusal plane to match that horizon, it may be too flat. And Zirconzan agrees with me, but some people I've seen talking about this say that you should set the occlusal plane flat and that it should be flat in the articulator. My opinion, it shouldn't. It should be closer to Camper's plane, which won't always match up with the horizon Camper's plane. Sometimes it doesn't. So really, if you want to talk about natural head position mounting, it's a method of transferring the occlusal plane to the articulator. I don't think it's a good method for determining what your occlusal plane should be. And certainly whatever method you're going to use, you need to test it out in the patient to confirm that it looks aesthetic. Don't do everything on the articulator and expect it to work out perfectly. So let's talk a little bit about vertical dimension. Let's see how I'm doing for time. I can get through this last part pretty quickly. The anterior closest speaking space, posterior closest speaking space, bite force, swallowing, VDR minus. There's tons of techniques for establishing vertical dimension. What's important is to use at least 2 techniques because there's no one technique been shown in the science to be accurate or repeatable. Resting is probably one of the worst ones. That'll change in the time of day, you know, so resting is good. That's probably what we were all taught. The one we most commonly see is Neisweimer's technique, which is VDR minus OVD. You get the patient, put the dots on the patient, the pleasure points on the patient's face, and you measure the difference between resting vertical, and you subtract 3 to get your estimated vertical dimension of restoration. The problem with that is resting vertical is variable, highly variable from day to day, from morning to night, patient sitting up, patient lying back. So you need to use one of these other techniques. Anterior closest speaking space is common. I'll show a video of that in a second. Existing OVD, so if the patient came in with teeth, you can copy that vertical dimension. Anatomical averages, you know, we see our wax rims, 22 millimeters from the vestibule and the maxilla, 18 millimeters in the mandible. The lip function is another one that we can talk about too. So the way that I do these, anterior closest speaking space, this is kind of pound, it's SB your guide, Silverman. So the patient's gonna count and we're gonna watch how close her incisors come together when she makes sibilants. And you can see in this patient, she's got teeth, but they're not coming very close together and her S sound is super slushy. It's like esh, because she can't get her teeth together. So we want those teeth to come about 1 millimeter when they're making the S sound. Any more than that, they're going to be a little bit slushy and your vertical dimension is probably too small. Any closer than that and they're going to hit and you've opened your vertical a little bit too much. Posterior closest speaking space is another one. We look at SH, CH, Z's, and J's. Some people will say church's chicken, things like that. When I go fishing, I'm always wishing some fishes I will catch. And you look at the premolars and see how close they come. And they should be about 1 millimeter or thereabouts too. And it's a little bit more difficult to see, but some people think it's more consistent too, like less adaptable. This is the M version. So using M and relaxation, it's the way I describe this is let the lips come into light contact and then get the patient to close. And you can see the difference in vertical dimension. So just you always use more than 2, use 2 or more techniques to verify where you're at with your vertical dimension. Another important feature of diagnosis using dentures, if we're talking about full arch implant prosthetics, is lip support. So here's a patient who got a hybrid denture. sorry, a fixed hybrid prosthesis on 4 implants in the maxilla. And here she is with her lip at rest, and here she is smiling. And what we see is this little fold in the lip and a lack of lip support. And this lip just travels a mile as well, because there's nothing to stop it from going up into that little pocket. So if we want to avoid having that happen, if we're planning these cases for patients, we've got to use a denture with a flange on it, or make a denture and cut the flange off and see what it's going to look like when you get teeth in there. And it is a problem with these patients. It's a significant problem. Here's a patient of mine that I did, and you can see he's got a mustache, but look, here's his lip. It's actually tucking under the hybrid. This is one that I did because this is the space. That's where his teeth belong in space. That's where how much resorption he had. And so this gentleman is not going to be suitable for a hybrid. This is an interim hybrid. He's actually going to get a bar over denture because he needs a flange. So it's an important thing, you know, when we're looking at these types of things, to be able to diagnose this. You don't want to have to fix it afterwards. It's a big pain. So let's talk a little bit about implant planning. I shamelessly stole this slide from Dr. Harris, who's a colleague in Louisville. And I think he's an IAG member too, and just a fantastic guy. If you ever get the chance to see him speak, he's a wonderful educator. This is a beautiful slide that shows the role of a denture in diagnosis for patients, or even a tooth setup. And you can see we need different amounts of restorative space for different types of prostheses. So on the left, we might only need 7 millimeters, and all the way over here to a bar and clip 16 for some bar designs might not even be enough. And the only way you can do that is with it. To determine how much space you're going to need is to do the setup, because some patients will present with this type of resorption pattern, and you're going to need to replace all that with pink. And some patients will have a ton of bone, and their incisal edge position will be this far away, or their occlusal plane will only be so far away from the bone, and they have adequate bone, and great, you can do fixed for them. But you have to be able to model the restorative space, and that's dentures. That is the wheelhouse of dentures, is modeling restorative space when you're planning implant prosthetics. It's really important. So moving on to like implant planning, I was trying to find a version of an analog surgical guide for implant pros. And this actually isn't technically an analog guide. I scanned a denture, duplicated it, printed it in used the digital file and cut a trough out here in the digital file, and then 3D printed this. So this is a denture duplicate with an out of bounds surgical guide. But you could just as easily do this with an analog denture or a denture duplicate. So you have the patient's denture, you like the tooth positions, you're planning the implants, you're not fully au fait with the digital, or you're not comfortable. You make one of these in a quick line denture duplicator with clear acrylic, and you cut the trough out and this is going to tell your surgeon where you want your screw channels coming out, right? So this gives him an idea, him or her, an idea of where you want to place your implants, or it gives them a guide. Okay, so that is a version that you can use. But if you decide to do this and you don't have a denture, or you don't have any way of communicating with the surgeon where your horizontal implant and vertical implant placement should be, you're going to have a bad time. It will end badly, because there's no reference points. Even the best surgeon in the world, they'll end up just putting it in the bone. You have to tell them where they need to go. So when we're working in the digital world, when we're using dentures to plan, I think the standard of care now really is using a CBCT, but the problem with that is it's very hard to introduce the data of a tooth setup into a CBCT, right? So there's a bunch of different ways to do it. People probably heard the dual scan. I think Nobel was doing that probably late 90s, maybe mid 2000s. And that's where you take a denture, you scan it in the CBCT, and then you put the denture in the patient's mouth and scan it in the patient's mouth. And it has these radiographic markers. I like to call them non-anatomic landmarks that will appear in both the scan of the patient and the scan of the denture. And the reason why the denture won't show up in the patient scan is because the energy required to get an exposure with the bone, or get an image of the bone, is a lot, it's too high for the denture. The denture will just be invisible because the x-rays pass right through it. That's why you do a separate scan. But this is a modified technique of that now, because we've got the intraoral scanners. We can just do a cameo surface scan with the Trios, or with another intraoral scanner, and I've put these stickers on the denture, and they are both radiographically positive and they're optically positive. They're a physical positive feature. So instead of doing a dual scan in the CBCT, which, you know, can be time consuming or whatever, or, you know, it's not as accurate too. Like a surface scan with an optical scanner won't have so many ripples. So then we take the denture, scan of the denture, and we can see down here in this image, those are the radiographic balls that are in the stickers. They're little zirconia balls, and they're also, you know, positive features in the scan. And we just take the denture and we superimpose it. We use those markers to align the two images. And now we can tell where the tooth is relative to the bone. And that's basically what we need to know when we're deciding to place an implant. So let's look at, just to wrap it up, I've got a couple of cases to show you. This is a patient I had maxillary complete denture, mandibular hybrid planned. So we start off with wax trims, you know, old school stuff. And on the wax trim, I've got the high lip line marked. I've got his canine marked, some midline, and you can see he's a little bit asymmetrical in the mounting, but that's because he's got an asymmetrical face. And we do an anterior setup, and I took that back to the mouth to try it and verify it because I was worried about this horizon issue, but it actually looked okay. And then we take the rest of the teeth off on the mandible, and you can see I've got, in this picture, I don't have them, but I actually put them in here, is these little cuts on the land area. Those are non-anatomical landmarks, so I can do an optical scan of this and superimpose it on a scan of the teeth, right? And then we can scan the patient. He's got teeth, so we don't need to use a scanning appliance, right? And we can just take the scan of our cast with the non-anatomical landmarks cut into it. We can superimpose our wax tooth setup that's done on the exact same cast. So this is an optical scan. Now we can see where our planned tooth setup is relative to our existing teeth and to the bone. So now I can see where I'm going to put my implants. For this case, I designed a stacking surgical guide, which I'll show you a different case where I did that. But basically, if you have teeth in a case like this, you should try and hold on to them because they can stabilize a guide. They're good. So this is just a kind of a conceptual showcase to let you see how we would use dentures in a digital planning sequence. So this is just a case I did. We saw this case already. It was the patient that had the hybrid where his lip tucked underneath it. And so he presented with dentures that were made in the pre-doc clinic. I evaluated them. I thought they met the anatomical expectation for outcome, for support, stability, and retention. In other words, I wasn't going to really improve on them. And aesthetically, they weren't terrible either. I didn't think that if I did a brand new one, I probably would have made them a little bit nicer looking, but I thought the tooth positions were good, so I was happy with that, and that's all I needed to do to move forward. So I took a scan of the maxilla and the mandible. These are duplicates of the dentures. Scan them, and then we take a CBCT, and this is like an STL rendering of a CBCT. So we take the CBCT and we convert it into a surface. And then we bring the dentures in. This is the dual scan of the dentures. You can see I've got the little markers on there. And this is what a dual scan looks like when you convert it to an STL, because the CBCT, each of those slices represents one of these little ridges. So I wanted to make a definitive or an interim prosthesis milled from this, and I didn't like these ripples. I didn't think they were great. So what I did then is I just superimposed the scan of the duplicate onto that dual scan. And you can see there's not as many of these ripples on here. It's going to be much easier for me to mill this part out. I'm going to have to do less work later. So here's the planned implant positions. And then now here you can see I've taken the denture and I've added some ports on here. And these are drill guides, so I can put pins to retain a surgical guide, okay? And the reason why I made this full contour is because I wanted to verify that I had everything mounted correctly for the patient, and the vertical dimension was going to be correct, and his occlusion was the way that I had planned it, or basically was a good copy of his existing dentures. So this is a copy of his maxillary denture. The tooth surfaces come from the mandibular denture. This stacks on top of a surgical guide, and I'll show you in a minute the sequence of how that works, so that I know that when I get done with all this, that my planned implant position is related to my interim prosthesis exactly as I planned it. All right, so these are the surgical guides. You can see now I put this maxillary surgical guide on after I've done the initial guide with the drill holes, and this is going to tell the surgeon how to reduce the bone. And I've done the same thing in the mandible. And this is a little strut that stabilizes it in the anterior mandible, and that's going to be cut off after we stabilize this with pins. So that's what happens there. It gets sectioned. Now the surgeon's going to come along and remove this bone because we need the space for the hybrid. We need restorative space for thickness of materials and strength and predictability. And so that's what it's going to look like when we level the bone, and you can see the implant osteotomies. And these are the surgical guides, and they sit on top of the reduction guides, and they look complicated, but basically these are where the implants will go in, and these little holes are just for irrigation, so we can inject saline while the surgeon is drilling to keep the implant sites cool. And this is the part that I like showing, is because, you know, I took the patient's denture, I duplicated it. It's preserved in three-dimensional space relative to its own arch. So I'm not trying to replicate the occlusion in the software. I already know that it exists and it's good in the real world. So I could literally work with one arch on its own and be confident that it's going to be, the occlusion is going to be good. I went ahead and verified it when I was in the surgery by making, you know, bites so that the patient bit in accurately and verified that I was, what I had in the articulator was the same as what's on the guides. But these little struts sit on the surgical guide. And so I know now that I've created a definitive relationship between my occlusal surfaces and my implants, and it's preserved by these struts on this surgical guide. So then I can just come along and pick up my implant cylinders in here with acrylic. And this is how this looks when it comes off. So I took it off the mill and I put some pink composite on here, and these are the surgical guides, and they're all stacked up on a print of the mandibular bone. This is how they're supposed to work in the mouth. But we just printed it off just to see what it was going to be like, because we'd never done it before. This is the bite verification. So I took this bite, or this jaw relation record, in the articulator, and now I'm putting it in the mouth, and you can see the teeth match up the same in the mouth as they did on the articulator. And this is stacking on the guide. So everything's fitting together as I planned it, but I'm still verifying it. I'm not going in there willy-nilly and just expecting it to work. This is after the bone reduction, implants placed. This is the converted mandibular prosthesis. You can see it's super easy because I pre-milled it. So this is quick. We can just inject the acrylic and pick it up. This is the maxilla. So here's why we need to verify, because this maxillary guide was not 100% accurate. The print sometimes will distort. And so when we did our initial osteotomy, it was here, not where we had planned it, here. So what I had to do is put the conversion prosthesis on and look through the channel that I'd left in the prosthesis and say to the surgeon, look, I want the screw hole to come out the middle of that channel. Because if we left it here, I'd have to hog out whole one side of that conversion prosthesis and we'd be in trouble in terms of strength. So this is what we end up with. And you can see he's got a significant deficit of tissue here. You know, like this is the day of surgery and he's got these shelves. And so we know he's going to need a denture. This is just to keep him going while the implants are healing. And eventually he ended up with a maxillary Marius bar over denture, mandibular Marius bar over denture. But you know, I would not be able to do this without being able to understand how dentures work and the diagnosis of dentures, et cetera, and how to transfer them and use them to diagnose an implant case. So I think, yeah, I'm not too far behind time. I haven't been keeping up with the Q&A, but let me have a look at it and see.
Yeah, you're great. We've got time. We've got about 25 minutes before we have to get set up for Dr. Tom Giblin. Dr. Giblin's going to be talking about incorporating digital dentistry into the modern practice, and there's a link there over in the chat box for those of you that haven't registered. Dr. Griseto, can you see the question there? I'll let you handle them since you know what you're doing with Zoom.
Yeah. So Justin, would you be able to make your lecture available as a PDF file? Yeah, I mean, there's nothing in, the only thing is I'll have to take out some of the slides that don't belong to me that I borrowed, because you know, so it won't have everything in it, but I'm happy enough to let you guys have a PDF. Okay. That's no problem.
We appreciated that. And, you know, sometimes I'm afraid we get our dental students on and they think it's dental school and that they can just ask for a PDF. And we've had to explain to them it's intellectual property. This is not dental school, but thank you for doing that.
Yeah, I don't mind. I mean, look, I'm an academic, so I'm happy to share things pretty openly. But I understand when people don't like doing that, because some of these things, they do have a bit of work in them. And the only other thing is I'm probably going to have to take out some of the patient photos too. But I'll have all the other information, like the literature, the most important stuff for people if they want to go looking stuff up. So I have the first question, hypergag reflex. Yeah, that's a tricky one for sure. And I kind of glossed over it. Yeah, they're very difficult. So there's two groups of patients that I'll categorize in the gag reflex. One is the patient who comes in and their gag reflex has a significant psychological component. So those patients will be gagging before you even put your hands in their mouth. And that's problematic. And I think some of those patients would benefit significantly from some cognitive behavioral therapy. There's an emotional component to their visit to the dentist. And we're just not trained to manage that. I mean, you can make an attempt to manage it, but that's outside of our scope of practice. I do think like we as a group really tend to neglect that side of our world because we're not really trained in it. None of our research, there's very little research in the dental literature on that side of things. So I would say if you get a patient in there that has a significant fear component, or they have, I call it a psychogenic gag reflex. It's like, it's a top-down mediated thing. It's not, you might not even be touching anywhere that would have a nerve ending that would stimulate a reflex. They just, they're just gagging. So that's the first group. The other group are patients, they have a gag reflex. It's not as severe, but it's definitely physiological. So you touch a certain part of the mouth and it stimulates a gag. And it's not just the palate. Sometimes it can be the distal third of the tongue. Honestly, the best way, and thankfully they're actually quite rare. But the best thing that I've had, the only thing I've had success with is desensitization. So you have to start with the patient and you have to increase their exposure time to the stimulus to allow them to desensitize. And there's a certain amount of neuroplasticity that's involved there. The patient has to be able to adapt and change their neurology has to be able to rewire for them to not have that gag reflex stimulated. So there's no easy answers. Now, if it's a short-term thing that you're looking for to fix a gag reflex, there's lots of things I've seen in the literature, like acupuncture of the earlobes, salt on the tongue. I find that this works in the patient to lift their legs off the chair. The other thing is breathing exercises. So a gag reflex is often stimulated because of a fear of a loss of airway. So if you train the patient to control their breathing and nasal breathing in particular, and you get them through breathing exercises, that will help them tremendously. I found like you can't gag if you're breathing through your nose. It's not possible. So, but some patients, they can't focus enough to control it. So it takes practice. I'm sorry, I don't have any good answers because I don't think there are any good answers when it comes to gag reflex. It's either psychogenic or desensitization. For stability purposes, is it necessary to have alveoloplasty to have the ridges at the same height, or is it okay to have high ridges of differing heights? It's another thing that I didn't really talk about because I was trying to stick to diagnosis, but pre-prosthetic surgery is very important. I think it's something that we don't do enough. So like undercuts, knife ridges, projections or deficits. Like one of the patients there I showed you, Bob, he had a significant deficit in his mandibular anterior. We could have considered grafting it even if he didn't want to have implants, just to get a better ridge for the denture, because it's a negative space. It's hard to get the denture to adapt into there. So I would say, in terms of, I don't think I've ever done an alveoloplasty to have the ridges at the same height, because if you think about it, if you're doing an alveoloplasty, typically you're losing ridge height, and ridge height is the most important factor when it comes to stability. So the resistance to movement in a horizontal direction. So if you're reducing a ridge to harmonize, you might be losing some ridge height. So I'm open to like different opinions on that because I've never had it happen, but I have seen those arches, where one side is super high and the other side is super low. But really in those situations, you'd almost want to be considering adding, and we all know vertical grafting is super unpredictable. So that's generally not great. So hopefully I answered that one for you. What do you like to border mold with? God, yeah, I've been on a rant about this recently. I like green stick, but I also hate green stick. Like throughout my dental career, up until like my latter half of the third year of my residency, I absolutely hated green stick. And then all of a sudden, because I was using a lot, it just clicked with me. And there's a couple of things that I would say about green stick. It's very much about temperature control. So you have to be precise with that. You need a water bath and you need to learn how it behaves. If you overheat it, it destroys its plasticity and it won't mold for you. So I would say try not to heat it more than twice, and then use the entire thickness. A green stick comes in a specific diameter for a reason. If a lot of people I see and students, I see them doing it in the clinic, they heat it until it's runny and they let it run on in this tiny little bead onto the edge of their tray. That's not how green stick was supposed to be used. It's supposed to be used in an entire thickness, and you divide the tray into like 3 or 5 sections, depending on your comfort level with it. And you use the whole thickness. And I put it on, I heat it enough so that it's, it's bending, and then I put it on the tray and I shape it with my fingers. Then I reheat it with a buffalo torch, not a micro torch. They're too hot. An alcohol torch, and I just reheat it until it gets shiny and just starts to slump. Then it goes in the water bath to be tempered. And when I temper, it's like I'm dipping it and it's out. I'm not holding it in there because a lot of the water baths, their temperature controls are kind of weak, and probably we should be using thermometers with that. But I just dunk it so that it's not so hot when it goes in the patient's mouth. I'm not really tempering it. But there are other materials you can use. You can use PVS. I find that PVS is a little bit harder to control from the point of view of eight upper dentures that with borders that are really, really thick when I use PVS. The other ones are like, it's not made anymore, but it's amazing material. I actually used it on one of the patients I showed today. It's called Adaptol. And you could mold the entire tray in one go. You just squeeze it out of a tube, and it's called mouth temperature wax because it molds at body temperature. And then you chill it with ice, and it's almost as good as a functional impression, which is my favorite. Functional is the best. You can't match a functional impression in terms of comfort, feel, accuracy, intimate fit. Functional is the best, so reline material, but Adaptol comes close. How do you mark the junction of the hard and soft palate to transfer the post-palatal seal line onto your model? Okay, so this is also a tricky one. I like to use two things. I like to use a clear denture base. So I sometimes will process an orthoacrylic denture base, or triad is okay. You can kind of see through it. But what I'm doing, you have to dry the palate. Like if you have a saliva covered palate, the ink from the Thompson stick is going to move everywhere. And that's the other thing I should say. You should use a Thompson stick, really old school technology, but it's pretty much the only thing. Some people use surgical pens too. You can get those purple ink pens, but it requires dry tissue. Both of them do. So you got to dry the tissue, and then the Thompson stick, just wet it a tiny little bit with a dab of water. And then, I'm getting the patient say, as I'm marking the seal. So I know that I'm not in an area that's too far posterior, and I'm just leaving the mark on there. And then I often do it after I've made my definitive impression, and I put the impression back in to transfer it to the impression. And so, yeah, Thompson stick, old school, dry tissue. And then you can use the butterfly where you thicken up the area into those lateral areas of the palate where the tissue is kind of spongy, but just get a feel for how much you can compress the tissue by using a finger or mirror handle. Or I've had patients occasionally say the denture is giving them a sore throat. Yes, your posterior palatal seal area, you've overextended too far distally. So we were talking about that earlier. The palate kind of drapes down a little bit. If you extend your palatal seal too far, that functional area is going to be rubbing, and rubbing causes soreness. Things that don't move don't rub, and they don't cause soreness. It's only movement that causes soreness. So if the patient says sore throat, the areas I look at are the palatal seal area, and then also sometimes in the hamular notch area, just distal tuberosities can be a little bit overextended. And then lastly, the retromalohyoid space where the flanges, the lingual flanges are, you can get a good bit of rubbing into the retromalohyoid curtain, that little area, that little caul of tissue that's behind the tongue. So look at those three, and then you're going to be good. You'll find something there, and you can use, if you're adjusting flanges, I like to use a thing called Phoenix paste. You can't really buy it. It's a mixture of Vaseline and PIP. And it's just a little bit more runny than PIP. And so it'll displace off the flanges a little bit more easily. Can you achieve reasonable post-palatal seal with 3D produced CD? What do you think about the overall quality? I didn't get a chance to talk about this today, but a milled denture base is actually, so we talked about our production methods. A milled denture base is not susceptible to the type of shrinkage that you'll see from a conventionally processed denture. And so some people out there are saying that you don't need a posterior palatal seal with these dentures. Now, that causes some consternation, particularly in classically trained prosthodontists, but I could see how that theory holds up. If we think that a good chunk of our retention comes from adhesion and interfacial surface tension and intimate adaptation of the denture to the tissue, then a milled denture base from an accurate impression is going to be superior to a processed denture base. And so, but I'm going to use a posterior palatal seal because I'm a belt and suspenders type of a person. So yes, you can absolutely produce a 3D digitally manufactured denture that will be equal to or better than a conventionally processed denture. That's my opinion. And I think the research data, early research data supports it. There are some drawbacks to the 3D workflow, to the digital workflow, kind of outside the scope of this lecture, but they are to me, it's the future for sure. It's just not quite refined enough yet. Like the aesthetics aren't as good, I think, as a conventionally processed denture. Have you heard of suction type dentures? Yes. So this is the other thing is the suction type denture. Suction is a misnomer. Suction doesn't actually happen in denture manufacturing. So what you're referring to is the idea that when you pull on the denture, it's retained. And that's the only time that actually you'll get a negative pressure under the denture is if you're pulling on it. If it's just sitting there, there's no negative pressure or suction on the denture. It's a kind of a subtle difference, but it's important because if you have suction in your denture, you're actually going to destroy your tissue. You'll get tissue hypertrophy under the denture. Patient will be sore. They'll come back with bleeding and bruising. So yes, just to clear up the terminology, but yes, the suction denture, there's a guy in Japan called Jiro Abe. He makes this suction effective mandibular complete denture. It's part of the Ivoclar BPS system. I'm not going to speak too much on it because I haven't done his course and I know he's rightfully fairly protective of his intellectual property, but I can say my basic understanding is that it hinges on this idea of a BTC point, the contact between the buccal tissue and the tongue and the retromolar pad. There's a point there where all three come together. Now, if you want to achieve that, your dentures have to be a little bit more or less extended than a typical mandibular complete denture, because if you extend that buccal shelf coverage out to that buccal shelf, you're going to push the cheek out and you won't get this contact between the cheek and the tongue. So I think it's a really good treatment for a lot of patients, but there are some drawbacks, but and it doesn't work for everybody. I think he says himself about 80% of patients, but if you ever get a chance to go and see him, I'd like to go and see him. I think it's possibly a really fantastic technique. Could you shed some light on your technique for selecting tooth size and shape? Yeah, it's always a confusing one. Honestly, like if you read any of these things that say the tooth shape is correlated to patient personality or face shape or anything like that, that's all nonsense. There's no science to support it. It just makes us feel warm and fuzzy inside. The best thing you can do is either get a photograph of the patient's existing teeth when they had teeth, and barring that, sit down with the patient. And so what I do is I don't show them the entire mold book. I narrow it down based on tooth size that I've selected. So the size of the tooth is going to be governed by how much their lip travels. And and also the intercanine distance, which you set with the alley of the nose. So that'll give you the width of the teeth of the anterior six, and then the height is based on lip travel. And then you can narrow down the molds that fit into that set of parameters. And then you can show them, the molds that fit there and then narrow it down further. Like I always find with patients, the best thing you can do is binary choices. Like if you overwhelm them with 10 different types of tooth shape, it's a disaster. And then they will be dissatisfied later. Like they'll come back and go, I wish I'd picked that other one that you showed me. Whereas if you say you can have this tooth or this tooth, then they'll be like, well, I think I like this one better. And they'll be it's the paradox of choice. And there's lots of psychological research on this actually, that the more choice you have, the more unhappy you end up later on. Like it's weird.
So along those lines,
Yeah.
when you're using the marking of the ala,
Yeah.
are you setting the canine, the center of the canine on that?
Ooh.
Or
I like that question, Dr. Hess. You're thinking. I think the classic lid is the center of the canine. It depends on actually the tooth molds that you're using. Some of them will have it at the distal of the canine, and some of them have it in the center of the canine. So you have to read the mold catalog that you have. It'll explain where it is. I think the classic teaching is the canine cusp tip, but some of them have it at the distal of the canines, and it's set on a curve too. So some of them, the measurements, so you have to factor that in too. But read your mold guide; it'll explain how to do all that stuff. Any pros for the wax room appointment for a completely edentulous patient? So yes, I do. I am actually a big fan of the anatomical average wax rim. That's the 22 millimeters from incisal edge to vestibule in the anterior, and then in the mandible, retromolar pad, and 18 millimeters in the front. That'll save you a lot of time. And then the incisal edge about 9 millimeters from the middle of the incisal papilla. So you get a wax rim back that's kind of in the ballpark. And then you spend less time messing around with it because, like we can spend a huge amount of time messing with wax rims. And then the other thing is, don't spend forever at it. You're not going to get the aesthetics perfect with a wax rim. Like I don't try and get it perfect with a wax rim. I only know what it's going to look like when I get teeth in it. Like some people can spend forever. Oh, lip support is not right. And like, I don't like this and I'm going to take away. Just get it in the ballpark, get your vertical dimension, get your jaw relation record, get some teeth set in it. Like don't faff around with it too much. And I'm a great man for wasting time with that kind of thing. So I think I can speak about that. But yeah, get the average wax rims back and get it broadly. You're not trying to make a final denture with it. Just get it broadly right, and you can make corrections later on. Remember, you're sneaking up on perfection. You're not trying to get it at every step. What's your favorite material when utilizing the functional impression technique? So the three main ones that people will know will be like Hydrocast, Viscogel, and Linol. I quite like the Viscogel. The only problem with the acrylic-based ones versus Viscogel is they will only support themselves up to about 2 millimeters. So if you're finding that the patient you're relining and you're finding that the flanges are like falling down on themselves, you kind of have to come back with like cold cure acrylic and support them, and then do another layer of functional impression. So whereas with the Hydrocast, it's more self-supporting, but then you got to be quick with it. It kind of breaks down somewhat quickly. But any of those, yeah, they're good. And it's important to just practice with the material that you use, so you know that its particular quirks, because they're all different, but they'll all get a very good result. Where did those stickers on the denture for scanning the source? Yeah, so those you can buy them from almost any, like I think Shine has them.
Blue Sky Bio.
Blue Sky Bio has them. Yeah, any implant company will have them, and they're super. Like the way I used to do this was drilling holes in the denture and putting gutta perca in, like classic pros-resident like nonsense.
Yeah.
And then repairing the holes. And the gutta perca is great because it really lights up on a radiograph more so than the little balls. But the stickers are super handy. Just make sure the denture is very clean and dry, because you don't want them moving when the denture is off, because that'll throw off your scan accuracy. Did Art have severe perio? Why not partial Artie? Art was probably the most difficult case I've ever treated. He had vertical dimension issues. He had worn down his teeth severely in the anterior, and they were edge to edge, and I couldn't change his vertical dimension because we tried it. And so what we were left with was like partial implants, retained natural teeth, which ended up being outside of his budget, or going like full hybrid over hybrid, which is what he decided for in the end. We debated that one. I presented it 3 times at interdisciplinary presentations in the residency, and like went back and forth on it, and eventually that's what we came up with. But I'm not one to be quickly taking out teeth, and it's something that I'm passionate about terminal dentition stuff, and it's really underrepresented in the literature, and the decision-making process is somewhat obscure, and we have to like really do a little bit more research into what the best decisions are. I do think the big thing is kind of age. We know implants don't last forever, so if your patient is younger, we really should be making more efforts to hold on to teeth, I think. Thanks for great. If incisal canal area has extra 2 millimeter or more tissue, should you remove it? Incisional canal area or 2 millimeters or more tissue. I'm not certain about that. Maybe you're talking about incisive papilla, that patient I was talking about earlier. Incisive canal enucleation, yeah, it's something that you can do. I would really generally only do it. It is an area of real irritation. Patients can get this burning sensation if you overload it, and you might not be able to provide adequate relief in the denture. So enucleation is an option. You can send them and it's reasonably well tolerated. There's no persistent numbness after it or anything like that. It doesn't really innervate too much up there. So yeah, you can refer for that. What's your opinion about flexible dentures? No. No, bad idea. So it's a whole nother lecture.
Yeah.
Partial dentures, my belief and my teaching, the school of thought that I come from is broad support. So recruit as much support as you can from the teeth and the tissue. And the only way to efficiently do that is to have a rigid major connector to distribute forces between everything. If you have a flexible denture, it's just, they're gum strippers. Great, fine for a temporary or a single tooth maybe even, but I'm not a fan of Nesbit's, but yeah, I generally steer clear of them. I have done them before, and patients love them, but I don't love them because the patient comes back and all their tissue's gone and they're impossible to repair. And anyway, that's just my opinion. Everybody is welcome to work out what's best for them. Jennifer says, do you think patients need socket preservation and bone grafting for patients who need dentures? The more I go on, if I'm talking to a patient, terminal dentition, we're extracting their teeth. Yeah, I do think it's reasonable to. Now, you have to be very careful with this though, because you can end up, and it's happened to me. I had it with a patient with a partial. They were grafted full arch for implants and eventually couldn't afford them. We came back. We didn't have room for like a flange and for teeth. You know, like a denture is predicated on the fact that you're going to have some resorption. So you have to be careful with that. But yes, if the patient ever has an idea that they want to have implants, a ridge preservation procedure is possible, but just bear in mind that you may have to do a surgical revision if you don't have enough restorative space, because sometimes it can be effective.
Along those lines, what are you telling your surgeon? Say you're going to do an immediate. What do you want him to do with the premaxilla and that angulation in the undercut there when they're taking the teeth out? Because
it's a nightmare. Like it is occasionally a battle with the surgeons. Like I am a person who's like, give me back an ideal ridge shape if you can. You know, if there's bone there and you've got a significant undercut, reduce that. Anybody who's done immediates knows that when you get to deliver the immediate, there's almost no room. A lot of times there's no room for the immediate, despite having hogged out the cast, like removed a ton of bone and set teeth on the ridge and everything. Like they're hard. And so the more and more I go on with immediates, the more and more I'm telling not only more removal of stone from the cast, but also more removal of bone by the surgeon. So now I'm getting to the point where I'm like, okay, we're taking the teeth out. I want you to remove the interproximal bone peaks, bring them down to the level of the buccal and the palatal bone height, so level it. And then if you've got a significant undercut, like take that in a good bit as well, because otherwise the patient's going to be miserable with their immediate. The more you can give a nice shape and have really nice tissue for them after the surgery, the easier the transition is going to be. It's always miserable, but we have a duty to make it as easy as we possibly can. And I get the reticence to do it. It's like, oh, we're taking away bone. What if we need it later? It's like, you should be thinking about that when you're treatment planning, and like, you can't have it every which way, but yeah, it's the premaxilla is a pain. Can you give a link to info on how to mark the palate for the most post-palatal seal and transfer it to the impression model? I have a series of photos that I might be able to post. I don't know the best way to do that. Maybe I could talk to Dr. Hess afterwards and we can organize something.
yeah, that sounds good. Thank you.
How are we doing for?
We're
almost up to time.
We're essentially out of time. Why don't you pick one of the last couple of questions there, and we'll again thank you very much for donating your time and your expertise.
Sure,
we really appreciate it.
Can we use a virtual articulator to duplicate the occlusion that we create chairside articulator? If it is, any precaution or pros and cons that we need to know ahead? So there's two ways of doing this. One is you actually take a scan of the setup that you did at the chair side, in which case you don't need to worry about articulation or any type of adjustment in the virtual space because you've already made it right in the mouth. That's my favorite way right now. The other way is doing it, taking that setup, scanning it, and then resetting teeth in the virtual space to kind of get it close or match what you've done in the real world. Two things about that. One, it's a lot of work. So your lab is probably going to charge you a little bit more. The other thing is that your occlusion isn't going to be exactly the same. So you're going to need to probably do some kind of a remount to correct any errors. So, but that, you know, at some point we're getting close to the point where the complete digital denture workflow is almost there, but then that's a whole other lecture as well. What's your opinion on taking an alginate final impression with a custom tray? Alginate, I believe, is a PVS impression material. So the one thing that I like about PVS is it comes in different viscosities. So you can change the viscosity based on the tissue quality that you have. So if you've got like mobile tissue and you don't want to displace it in your impression so that you capture kind of in a static way, you can use a really runny material. And then if there's another part of the mouth that has thick, so this is like the Dr. Massad technique. Alginate is a single consistency, and I think you're going to end up with a significant overextension. Unless you border mold, you might be okay, but generally not. Now, if you're doing it for an immediate, have at it, because you're going to spend your life adjusting it anyway. There's no need to make a perfect impression for an immediate. Does having fewer denture teeth second premolar to second premolar have any effect on stability, retention, or support? So occlusion does have a role to play in stability. I didn't really talk about it. The only thing about that is it may affect your protrusive balance. So as the patient slides forward, if you've got less teeth at the back, it's hard to balance that protrusion, and so you can destabilize the maxillary complete usually. viscosity do you like for border molding is medium good. I don't actually use it, so, but yeah, medium, like medium body would be good. Something, you want something that's going to sit on the tray but not fall off, basically. All right. Thanks, everybody.
You got to them all. So go ahead, stop sharing your screen. I'm going to share my screen again so people can see our upcoming webinars. And just a reminder here at 2:30, we have Dr. Tom Giblin will be presenting on incorporating digital dentistry in today's practice. Dr. Griseto, thank you very much. You're welcome to jump off, and you're welcome to join us with Dr. Giblin later.
Yeah, I may do that. I like Dr. Giblin.
All right. He'll be pleased to hear that you like him.
Yeah.
All right. You take care, sir. Thank you very much.
Thanks so much.
All righty. I'm just going to pull up this PowerPoint here that has information about upcoming webinars. Again, the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series is only possible because of the donation of time and the expertise and these lecturers doing these presentations for no honorarium. We appreciate that. We unfortunately have a limit of only 3,000 people on webinars. That may change in the future, but so if there's a webinar that you're interested in attending, you need to register, but that just does not guarantee you'll get into the webinar for sure. We just have no way of controlling that. I'd like to thank our partners, Seattle-King County Dental Society, Pierce County Dental Society, Snohomish County Dental Society, Patterson Dental, Comet USA, Canadian Academy of Restorative Dentistry, and Prosthodontics. We want to thank the University of Washington School of Dentistry CE Department for handling the CE certificates. Be looking in your email at box in a couple of days. You should see an email from the University of Washington with your CE credits. We have one more speaker today in our International Academy of Naphthology Day. Tomorrow is Arkansas AGD. You really want to see our first speaker, Dr. Rick Robley. He's got a fantastic presentation you don't want to miss on everything from surgically facilitated orthodontic treatment and then utilizing Invisalign. He's going to show some stuff, 30-year cases, follow-up, etc. So that is one you want to get registered for. There's QR codes on all these flyers, but feel free to go to washingtonagd.org to also see the upcoming webinar offerings. I mentioned earlier before the webinar started that we have some things planned for next week that will focus more towards on your staff and getting up and running when we get back on May 18th. If you missed a webinar, go to YouTube, Washington Academy of General Dentistry. You can follow up with that webinar there. Please feel free to share the link to our YouTube page, and don't forget to follow us on Facebook. For those of you that are interested in completing your master's in the Academy of General Dentistry, we have a wonderful master track program that we host here in Seattle. We have our own educational facility. We have 5 chairs for hands-on, and that's master track program is really designed to take a person from right out of dental school and turn them into a master in a period of about 5 years if you follow and stay with the sessions and do your case presentations. Well, that's about it. We've gone through the flyers here again. Look forward to seeing you in about 20 minutes here for Dr. Tom Giblin's presentation. All right, Val, I'm going to stop the webinar and we'll get set up for the next one. Thank you.
Thank you, Dr. Hess. Thank you, Dr. Hayamoto.
You're welcome. Thank you, Val.
Thank you, Dr. Hayamoto. Appreciate it.
Good job, Tim.